All right, guys, it is now 9:30, and it is the first day of December. Just took the pharmacology test. Overwhelmingly did well. Had a couple of hundreds, some 95s, some 75s. That's passing. And that's all that matters. If you didn't do as well as you wanted to do, you will be able to find the PNR for pharmacology in the module after a little later today. Also, I want to show you a few things about what's going forward. Okay, don't forget that I sent out an email about my days to be at home. Concord is doing like a reduction of staff as far as just being on campus. Same hours, just not as many people on campus if necessary, even if it's not necessary. So Monday and Thursday are my days to be at home. So if Monday and Thursday is just a lecture day, you'll be lecturing from home. Okay, just go stay home and log in online. All right. If Thursday or Monday happens to already be scheduled a major lab day or something like that, then we will be here. If it's a test day, you still come. And what happens, you'll just come and take the test and go home. Okay. Other than that, if it's just a regular, just doing some lecturing or reviewing or anything like that, it will be from home on Monday and Thursday now and going forward to the next class until the vaccine is here and gets in everybody's arms. So we're looking probably next March before we get back to normal. Okay, around next March or April, everything should be back to normal, hopefully, unless there's a COVID-21 that comes in. Okay. All right. So let me show you a little something else here. I'm gonna share my screen for these modules. You just took pharmacology. It's closed now, but it's still available for you to go back and study. Okay, all of the modules are still here. Okay, starting from 210A all the way up to now. Okay, you have your field exam practice with the PNRs there. Then you have your A, B, C, D. The E was acid base, then gas laws, medical gas therapy, humidity, pharmacology. All of those are still open for you. You should be going back. Don't forget, you study old stuff. Always go back to your old modules, look at lectures, look at PowerPoint, study. Just pick you a page and study that page. You don't have to study it all of them every day. Just pick one, like on Monday. Mondays, you might go to RT10A, look at a few things. And on Tuesdays, you do B. On Wednesdays, you do C. Thursdays, you do D, and so on. Okay, Saturday and Sunday, you also do these. Not only do you study what you own, but every day of the week, go back and pick a section to do a little perusing. 15 minutes, right? If you know, it don't have to be 2-3 hours on the old stuff. Just go back 2-3 minutes. I mean, about 15, 20 minutes in the PowerPoint just to kind of remind yourself, seeing it, because repetition and seeing is what's going to help it stick, because the final and the orals are coming up. All right. Also, I want to show you after hyperinflation, obstructive and restrictive diseases. We're going to talk about today, or this section is going to talk about why we need to hyperinflate the lungs. Okay. And also, we're going to talk about obstructive diseases and restrictive diseases. We talked about COPD is what you're going to see the most in the field. People who can't get the air out, right? Those are your obstructive disease patients, chronic hypercapnic patients, because they cannot get the air out, so they can't get the CO2 out. So they always have a high PCO2, okay? And so we're going to talk about those particular diseases that are lined up with obstructive, the CBAVE diseases, the cystic fibrosis, chronic bronchitis, emphysema, asthma, those type of diseases that make up COPD. And you're going to learn how they manifest. How do I know one from the other? And then how do we treat them? Okay. Then another lecture will be restrictive diseases. What keeps the air from getting in, right? For instance, if I have scoliosis and my spine is S-shaped, my lungs can't expand like they want to. That's a restriction. If I have kyphosis, where I'm bent over like a hunchback, my lungs cannot expand, so that's a restriction. Okay. remember we said compliance, the lungs will do whatever you want them to do, right? For high compliance. Well, if they won't do what you want them to do, that's a restrictive or low compliance. All right, so we talked about things with low compliance would be like consolidation, fibrosis, right? When the lungs are stiff, that's a restrictive disease. Or if it's skeletal, there's going to be several types of restrictive, either skeletal, neurologic, right? There's some different types of restrictive diseases, and you're going to learn like kyphosis, scoliosis, pectus, pigeon chest, or caved in chest. Those are all skeletal restrictive diseases. Then you have some that are pulmonary, like pneumonia, pulmonary edema. When it's full of fluid, it can't expand because air can't get in to make it expand. So if it won't expand, it's a restriction. Okay, abdominal. What would be an abdominal restriction? What was something that's got to do with your stomach, keep you from taking a good breath?
Surgery.
Surgery, now that might be a condition for why you won't take a deep breath. That is right, and that's why we do some hyperinflation. But as far as a disease or a restriction, some type of restriction to keep your lungs from filling up, that's got to do with your stomach. Overweight. Well, but what about women in particular? Pregnant. Well, if you got triplets in there, you can't take a deep breath because the diaphragm is being depressed. It can't do what it wants to do. So ascites is a lot of fluid in the stomach, right? It's nasty. It looks like an underground river, right? It has to be drained. Or somebody who has a huge beer belly, right? Or pregnancy, stuff like, or tumor. If you have a huge tumor in your abdominal cavity that keeps your lungs from doing what it does. Those will be abdominal restrictive diseases. And every class has a few of them listed. And so you'll need to know those, okay? All right. So for today, we're going to focus on obstruction. Then we're going to do restriction. And then the next day, we're going to talk about hyperinflation. Why do we hyperinflate? Like, I think that was Miss Woods that said surgery. When we have somebody going to surgery, say you get cut up here in your upper abdominal region where your diaphragm is. The closer the cut to the diaphragm, the more it's going to hurt. The more that you want to not want to take a breath, right? And so people who don't want to take breaths or scared to take a deep breath start to develop atelectasis. We said that's when the little alveoli closing. That's atelectasis. And we don't want that. So somebody who's coming out of surgery, somebody who's heavily sedated, right? Those are people who are not taking deep breaths. Maybe even people who are paralyzed. Those can't take deep breaths. So we practice maneuvers to help them take deep breaths. That's that incentive spirometer that you see on the side of people's bed that I showed you the other day. The little handheld device that you breathe into and the little bellows goes up in the patient's room. You ever seen one of those before? That's an incentive spirometer. That's for the natural way to hyperinflate. But if that doesn't work, we can do forcefully. This is when we're going to start introducing positive pressure into the body, okay? In hopes to pull those lungs open. All right, and they'll pop those alveoli back open, pop, 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 pop. Right? Once they start closing, they snap back open once you take a deep breath or if I force the breath into you. All right, so there are going to be indications, contraindications, benefits, hazards, all that kind of stuff of hyperinflation, whether it be negative, because when you take a deep breath, that's negative, right? You're becoming more negative than outside, so air comes in. That's natural, so negative is natural. And then positive is when I have to force it, okay? You're not going to breathe deep, then I'm going to have to force it in you, okay? And you can see that that's going to cause a lot of different effects to the body if I have to force air into you, okay? Because I can pop a lung if I do too much and cause a pneumothorax, right? All right, so that's what we're getting ready to get into now. This is the last one. So I want to show you this as well. Down here under that is the final exam and oral review, okay? Now, this is a whole section just for review for the final exam and oral review. I have the, I'm going to get rid of this syllabus for this term because that's old. That's the last syllabus. Okay. But you see from September. I did a live lecture in September over the review. I'm going to do more live lectures, okay, that up to date, but I'm gonna leave the old ones in there if you want to go back and look at last term's lectures just to see if I missed something or you missed something from this one that I said last time. As much as you can get is I'll leave it there for you, okay? These little quizzes like this attendance quiz, I'm getting ready to get rid of that because that's old. This homework for that day is old. Only thing I'm gonna leave is the lecture. I will leave the lectures and I will add to the lecture. So you see 925, you know that was last term, okay? But when you see 12 something, that's the one we're doing now. So you get free reign to look at all of them if you want to. All right. We have the study guide for A, A through C, study guide for D, study guide for E, F, G, H, I. All of those study guides are there for you in one space. If you want to pop them open, they're all in one place right there for you to study for your final. There is no study guide for J because we're going to be just doing J when the final hits. There's no need to go back and do a whole study guide for J. It's already, you're doing it now, okay? You're doing it now. And then finally, the final exam, which is unpublished, okay? Then after that, you have your, of course, your CPR. That's your basic life support module. Opening up the module for basic life support. The basic life support or BLS, you have 3 sets to watch. Please pay attention. The way that this happens is not for you to do right now. I'll let you know when I'm going to close it back right now, but I'm just opening it to show you. How it's going to work is you got to come to BLS part 1. Okay, you'll hit this one right here. And it's the video. Okay, it's going to be the video. You come down here to preview. And you'll start. Now, as I watch the video, it's going to say certain things and the answers, I have to put the answers. This is not for a grade. BLS part 1, 2, and 3 are not graded. They are just to make sure that you're watching the video. Because if you go through and try to take the test, and the test is not going to be open until you have watched all 3 videos. And we can see who's watching them. So for instance, if this video is 17 minutes and you only watch 5 minutes of it, we're not going to open it up for you. You have to watch the videos in their entirety. Because any other time we would be in class watching the video for CPR. Going through it, stop, practice, watch it, stop, practice. And so Corona hit, we had to devise this a little way of doing it so that people could watch the video and make sure, because AHA is not a joke. You can't just, it's just something to do. This is saving somebody's life. Okay, even if you already have your CPR, you must still watch all of these videos and then take one of the exams. Now, so for instance, when I watch this one,
heart disease is the #1 cause of death in the world.
See that? Heart disease is the #1 cause of death in the world. What's this first one say? Blank is the #1 cause of death in the world. So I will come down here and put what? Heart disease. That's just letting me know that you're watching it, okay? That's just letting them, this one's 2 minutes long, okay? Then you go to the next one. It will be another part of the video, right? You'll start watching that.
Those are just a few stories of providers who are important to read.
All right, so heart attack is not the same as cardiac arrest, right? That's what you just said. The word heart attack is often misnomered as cardiac arrest. It's not the same. So I will put not the same. And keep on listening and answer these little questions here, right? This is a 17-minute video. If you only watch 3 minutes of it, we're going to know you only watched 3. We can see it in the canvas, okay? Watch it all as you answer the questions, because you still, even if you answer both questions, you still got to listen to the rest of it, because there are going to be techniques in there you're going to have to know when you come check off. All right, so when you watch all 3, BLS part 1, part 2, and part 3, we will open up exam A for you. You have to pass with an 84. Okay, if you don't pass with an 84, you have to retake it. All right, but when you retake it, it'll be part B, test B. Okay, now BLS is open book. So you'll be looking at the videos. You can do whatever you need to do to pass that test. Okay, we have a book that you have that's the BLS book, the little thin blue book. It's open book. So if, when you're here taking that exam, you can open up the book. So it should be an easy 100. The BLS exam should be an easy 100 for you. Okay. If you fail the first one and you don't get an 84, then you must take it again. You have to take B, and then you'll score, hopefully you'll score at least an 84. You can't get an 84 and say, can I take it again so I can get a higher grade? It's not going to do that. As soon as you make an 84, that's it. So if you take the test one time and you pass with 84, you're done. Okay, that's your grade. If you get an 80, then you have to retake the test. All right. So you need to get, I mean, this could be an easy 100 for your grade to boost you up. Okay, to boost you up. So that's how BLS will be handled. And it will be handled soon. Probably after this lesson, I will open it up, but you need to start, we'll be practicing for orals and finals, and then after those, you'll knock out your BLS, okay? But, you know, if it's a weekend and you, hey, I want to go ahead and knock out watch my videos and get it out the way, that's fine. But we don't want you to be way here doing that, and then you're not, because you can't come to check off to that lab. That is a BLS lab. That's a CPR checkoff. You're going to come in. You're going to have, I'm going to have the mannequin laying there and say, go. You need to be able to say, hey, you okay? Know how long to check the pulse, how long to look for breathing, where to put your hands, how fast you should be compressing, and all of that, because it's in the video. If you didn't watch the video, you won't know. And you're like, well, where I put my hand? You're going to have to go. You're not going to get it. Okay? And it's pass or fail. If you do not complete this, you will not pass the course, the whole course. All right, so take it serious. This is not a joke. All right, not a joke. So this is how it will be handled for BLS. Question? Yeah, what grade? Yeah, the BLS is for this. That's what I say. It's an easy 100. It'll be an easy 100. You have RT210J test left. Then you have the CPR test. Then you got oral and final. Okay, so the CPR could be an easy 100 for you. All right, it should be an easy 100.
Are you saying CPR?
Yes.
Oh, okay. I'm not.
All right, so now that is what we're doing for the BLS. All right, that's what you should be expecting for the BLS. Like I said, those videos are part 1, part 2, and part 3. You have to complete all 3 parts. Here it is right here. Get back to it so there's no confusion. Okay, here it is. BLS part 1, that's video with those questions. Part 2, video with those questions. Part 3, the rest of it. It's a long video. It's a whole day worth of stuff. So it's not something you can do in 25 minutes and be done. All right, it's the BLS video. Must watch it all. Okay. After you have watched it all and you email me and say, hey, Mr. McCarthy, I'm done with my 1, 2, and 3. I'll look to see that you completed it, because if you didn't complete them, say you didn't watch all of part 2, go back and watch it. All right, you have to watch the whole thing. Now, whether you turn it on and go leave and do something else, I won't know. But I'll know when you come check off and you don't know what you're doing, I'm going to send you home. Okay? This is not a game. This is saving somebody's life. And you'll be Concord student in the clinicals doing this on somebody. Because somebody's going to code while you're there. And they love to use the students to rotate in and out for compressions. Okay? So when you get in there and don't know where to put your hands and they're going to tell you get out the way. And they will let us know, hey, she don't know or he don't know nothing about CPR. What's up with that, right? So you're going to be in and out, and you can't be too prissy, because you might have to be up on the bed doing compressions, draws showing, all of that, right? So make sure your clothes are not too tight. I'm just being serious. This is real. People, when somebody dies, people are up in the bed with the patient compressing, especially if you're short and not that strong. You might have to get up in the bed and be compressing. You got to do it right. It can't be, well, I'm just trying to make sure.
All in the feces and all.
Whatever is there. But you got gloves on and all of that. But you can't be too worried about your hair and worry about this and nails, and that's why you don't have all of that when you're in the hospital. Okay. And so make sure your scrubs are not too tight or too revealing and none of that, because it's gonna be on display once you're up in the bed. Okay, and be embarrassed. All right, but this is somebody's life, so we're not playing with the BLS. Okay. Now, Once you take those part 2, 1, 2, and 3, I will open up either exam A or exam B for you. If you have opened up past exam A, you're done with BLS. If you fail exam A, you must retake the test, but you'll have to take test B. Okay, question? Yeah, we'll have days of review for the final. Yeah. So so that's how that's going to go, guys. And that's, like I said, after BLS, you got you'll have a new module that pops in that says oral. Okay, for your oral, because you're going to have to. It's going to be a Zoom link for the oral, but that's not through me. I do not do your orals because they don't want me to show bias to the students. So other respiratory instructors will be the ones who pop up on your screen and ask you these questions. Those oral cards that we basically practice every now and then, that's what they're going to ask you. Okay, they're going to pick 20 for you, and you're just going to have to answer them. All right. You must pass with a 75 for your oral. If you get less than a 75, you fail the oral, but you can't retake the oral. And it's very heavy. It's 16% of your grade. These tests you've been taking have been 4 or 5%. The oral is 16%. So if you bomb the oral, you're going to drop you down pretty good. And the final is 26%. So if you bomb that, it's going to really brought you down. Okay? So that's why we take so much serious on going back. Laugh from the past, go back and practice that because it's on you to know that stuff.
So the oral will go from home?
Probably so. But you can't have, there with the way Corona is, they've got to the point where they know to watch for eyes. When eyes keep going off to the side, they'll stop your test. If anybody say anything in the background to you or your phone is ringing, test is over. Okay, because this is very important, and a lot of people try to cheat. Have little stuff right there. So I ask you something about something, and you keep doing this. I'm looking right at you. You're looking down. I can see reflections, and some people have glasses. You can see the screen on their glasses. I mean, it's just ridiculous. Okay. But now, now that we last term, we wasn't taking every test on campus. We had just gotten back to that. Okay. So now that we're taking every test on campus, you definitely will be taking your final on campus, okay? The oral, I don't know if he's going to keep that online or is he going to make you come in for that too, okay? Now that we're doing tests online, it's very, very possible that you'll be taking your oral face-to-face with your instructor, okay? So like this far, all right? And then that way you can pick your own cards if you're here. You can't see them. They're not color-coded. They're just different colors, but they're not sectioned off no kind of way, okay? So we'll shuffle them up and just spread them out. You can grab 20 cards, and then that'll be the cards we ask you. Okay? If it's online, then we pick the 20. But we're going to just shuffle, and then 1, 2, 3, 4, 20, and then pick them up. That's it. Nothing particular. But I do tell them to make sure that you have at least 3 or 4 ABGs. Because you got to know ABGs to get out of here. Okay? So you got 20 questions, you don't have no ABGs, that's not going to work for me. Because I got to make sure that you know ABGs. All right. Because that's what a therapist is, an ABG reader. Okay. All right. So let's go on with the lecture. I just want to get that apart. I've been recording everything I've said. If you missed it, you can go back and see anything you might have a question for. And now we're going to go on and go into the lecture. Today we're going to do obstructive diseases.
You know the oral review already on here, right? It's got the wrong date, but it's on here.
Oral review, that's fine. It's just some. What are you talking about? It's the study guide right here. You talking about this right here? Yeah. The final exam and oral review. Am I sharing my screen?
I don't know.
Is it moving?
Oh,
okay.
I'll still look at it.
Yes, this right here. Final exam and oral review. Like I was saying, it's recorded, but these are old lectures from last term that I was lecturing on the review. Like all the other sections, I erased those live lectures and start them with new, okay? This is new every time. But for the review, I'm going to keep the old ones so you can look at those and the ones we do, just for extra practice, okay? And all of the study guides are here for you to see. You can go, if you're not sure about a section, go to that study guide to make sure you got what you need to get and make sure you're going back to study what you got to study to pass. Okay, it's all there. I opened it up just now, except for the final exam, of course. All right, so that's open for you to study as of today. Okay, all right. Hyperinflation. The hyperinflation module will have practice and review blast from the past documents. You'll be working on that one. I'm going to unpublish that one for right now because that's going to be one of your homeworks that I'll be using for homework. We'll have a comprehensive practice document. It's more practice. Hyperinflation note-taking guide is here. Hyperinflation PowerPoint is here. Obstructive disease note-taking, and you have restrictive disease note-taking guides are here. All right, and as well as both the PowerPoints are here for you to look at. After we go over, this is the one I'm finna do, this obstructive disease. When I'm done, you want to go back and look at it, it's right here. Okay. Same with the restriction when we get to that. There's a hyperinflation video on YouTube we'll watch. We won't record it, but we'll watch it. And then flow volume loops, I think this is a discussion. I'm getting rid of that. We're about to discuss. Matter of fact, I think that was a video, but it wasn't. It was really too much. All right, so let's go ahead and go to our PowerPoint. Obstructive diseases. Remember we said the obstructive, when somebody has an obstruction, they can't get the air out, right? And if you can't get the air out, then you are retaining carbon dioxide, okay? That patient is known to be a CO2 retainer, okay? Which is hypercarbia, hypercapnia, right? Very acidic all the time. All those things that pertain to CO2, okay? Not ventilating well. They can't get the air out, okay? But we said the disease that we see the most for obstructive diseases is COPD, okay? COPD is chronic obstructive pulmonary disease. It's chronic. It means it's forever, okay? It's been happening for a long time, okay? And there are certain diseases that make up COPD, okay? So I like this little picture here. It says the real reasons dinosaurs became extinct is they got smoking cigarettes, okay? They were smoking cigarettes, and that's why they're really extinct, okay? Cigarette smoking will kill you, all right? It will kill you. And what it does is it feels fine you might wake up one day and be like 2 times less than what you could do that day before. It doesn't have to be, when I start getting kind of bad, I'll quit. It can be overnight, right? It can change overnight your ability, your spirometry values, right? Your FVCs and your tidal volumes and IRVs and all that kind of stuff. Those numbers can change overnight, okay? And pulmonary diseases are irreversible. Once you get one, you got one for life. What's wrong?
Oh, okay.
No, that's what I did. Yeah, that's why I gave you obstructive diseases and not the one for J. Well, J that's hyperinflation. I'm gonna do hyper. I gave y'all a restrictive and obstructive disease power. It's a handout. I gave the handout to y'all. Restrictive and obstructive. It said one says restrictive note taking guide, and one says obstructive note taking guide. Yeah, I could have swore I gave it. If not, you can print it out. But I could have swore I gave that to you because it's J is 3 things. J is hyperinflation, restrictive, and obstructive. It's 3 separate things in J. Okay, I usually start with hyperinflation, but this time I'm going with obstructive and restrictive. Then I'm gonna do hyperinflation last. Okay.
That's one page.
Yeah, that's what I'm saying, because that's why it's not that much in J. That's what I mean. Because J was originally just hyperinflation, but they added restrictive and obstructive to 210, so that's where we put it. Okay. But if you don't have it, then you just have to you'll have to make the what you call it. Hold on one second. Let me stop the share right quick. Let me pause it. Okay. So I just realized you guys didn't have the obstructive and restrictive disease note-taking guide that's printed out already. So for those who are here, I went ahead and printed it out. If you're at home, it is in the module. The note-taking guide is in the module, so you'll need to print that out, and you can take notes with it as you go. Okay. If not, you can watch this video again a little later and take your notes. Go back and put your notes down. So if I were you, I'd be writing some separate notes somewhere else as I go through these. But the PowerPoint is available to you. I'm not going to take it off, so it's always going to be here. And when you get the paperwork itself, excuse me, you can catch up on your notes with that. All right. All right. So obstructive diseases. Objectives of this will be to give PFT data for obstructive diseases. Okay, PFT or pulmonary function test data. If I give somebody a pulmonary function test, I expect to see certain data, right? If they have obstructive disease, I expect to see another type of data if they have a restriction disease, right? For instance, the FRC. Somebody with obstructive diseases should have what type of FRC compared to somebody else? Increased, because they can't get the air out. So the FRC is going to be larger in a COPD patient, right? So those are what we're talking about. PFT data, whether it's simple spirometry tests or the ones you have to actually get into a body box and test, right? There are certain PFT tests that you have to be in a certain box, closed up on this chair in this body box, and you'll have a mouthpiece in your mouth connected to a computer. And the therapist will be telling you all kind of stuff to do. Breathe in and out, in and out, in and out, in and out. Stop, stop, stop. Deep, 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 blow, blow, blow. All kind of stuff going on, right? For different types of tests. That data will then be put on a graph and printed out for the pulmonary doctor. Okay, that is what has to be done first, because that lets us know what level. This is too much. That lets us know what level of COPD you have. Are you level 1 type? What I'm saying, are you at stage 1, stage 2, or in stage? Okay, because if you're in stage, I don't want to be treating you like you're first stage, right? I need to know how far along your COPD is so I can treat you correctly. Okay, go ahead and give you the max. If you're at end stage, I need to be giving you the max treatment, right? But if you're just beginning stage, I don't need to give you max treatment for beginning stage. So the number one thing you do to know, or the gold standard, okay, that's what they call the gold standard. I want to write that down. The gold standard to treating COPD is a early PFT. The gold standard to treating COPD is early pulmonary function test. Have to do that first. Have to. If I do that first, then I can go from there. How far is it? Gold. Like gold, metal gold. Like this. Like my chain. All right.
Early what?
PFT. Pulmonary function test. All right. So not only are you going to give data or know the data for obstructive diseases, but differentiate between obstructive and restrictive. Know the difference between an obstructive disease or restrictive disease. Differentiate between and describe the manifestations and treatments for the various obstructive diseases. So for instance, emphysema is a COPD disease, right? So it's one of the C-babe diseases, but there are different types of emphysema. You need to know how to tell me the different types, right? And how they manifest, okay? Stuff like that. Here we go. Obstructive diseases are the C-baby. You got COPD, baby, right? You remember it like that. That's the C-babe diseases. The C-babe, cystic fibrosis, bronchitis, well, chronic bronchitis, asthma, bronchiectasis, emphysema, and bronchiolitis. Cystic fibrosis, bronchitis, asthma, bronchiectasis, emphysema, and bronchiolitis. Those are the C baby diseases. You got COPD, baby, right? All right. Now, the trick is, what they tell you, if you have 2 or more of these, then you have COPD. Just because somebody got asthma does not mean they have COPD. But if they have asthma and bronchiectasis, or asthma and chronic bronchitis, now they have COPD. So 2 or more of these, right? If somebody always has at least 2 or more of these, then they have COPD. Now they got because this chronic bronchitis and stuff like that will lead to this one, right? Smoking can get you here, but not only that, but chronic bronchitis and asthma, those things start to scar on the lungs and cause you to have emphysema, because emphysema is simply floppy lung. Emphysema is known as floppy lung, right? And you can either become floppy because of your smoking or other conditions that have stretched it out and damaged it. Now it's just floppy, right? So 2 or more of these, now you have COPD, okay? All right. It's a disease characterized by preventable, treatable airflow limitation that is usually progressive in nature, not completely reversible though, and having an abnormal inflammatory response to noxious gases or particles. All right. It is, now this part right here, you don't have to know for the test. It's just more information. COPD is the 3rd leading cause of death in the world, behind heart disease and cancer. Behind heart disease and cancer, cigarettes is what's killing us. Okay? Just kind of puts it in perspective. 24 million are estimated to have COPD, and that was when this was done. So this is only a few years old. 15 million diagnosed every year. 715,000 annual hospitalizations just for COPD. So that's good. That's job security for you, right? As long as they keep smoking, you got a job. All right? $50 billion a year cost. And then if they don't have insurance, guess who's paying for that? We are. Okay. All right. Now let's start with the first one. Chronic bronchitis. Chronic bronchitis. Definition is chronic productive cough of unknown etiology. Like you don't know where it comes from. It just comes. And it lasts for 3 consecutive months and happens at least twice a year. That's chronic, right? Chronic bronchitis is if you have a productive cough and you don't know where it's coming from, but you got that cough for 3 months. So say you started coughing in January, you kept coughing through February and March, then it finally subsided. But here in June it comes again for 3 more months. That's chronic. So that's 3 consecutive months for more than 2 times a year, or 2 or more successive years, right? So you got it 3 or 4 months this year, and the next year I had it for 3 or 4 months. Like every year you know what I'm saying, I seem to have this long cough. That's chronic bronchitis. Okay, that's chronic bronchitis. What causes chronic bronchitis? Number 1 cause is smoking. Repeated infections, occupational exposure, or air pollution. So you see your mucociliary escalator right here. Remember that? You have your columnar epithelial cells. And then on top of these, you have what? Cilia, right? And then in between these type of cells will be my what? No, that's not mucus buildup. This is a cell. This will be a cell in between here. No, huh? No, what cell is this that produces all the mucus? That's the alveolus you're talking about. This is not in the alveolus. No. The cell that produces the mucus in the body. There's a cell that produces. No, that's y'all talking about the alveolar. This is not the alveolar, guys. This is up the large.
Phagocyte.
Oh, the mucociliary escalator is on your trachea and your large airways. The type 2 cells and stuff, they're way down in the alveoli. Which ones produce gobs and gobs of mucus? Goblet cells. So your goblet cells will be right in here and will be pouring mucus, right? That pour mucus up for the mucus blanket. And then the mucus blanket itself has two layers. It has the what? The layer closest to the air would be what? Mucus has two layers. See, this will be stuff like oral questions. What are the two layers of the mucus blanket? You got to know that. The layer closest to the air traps all the particles. What layer is that? The top layer of the mucus blanket. You got your mucus blanket right here on the screen. Look at the screen. This is the mucus blanket right here. All this mucus is just a blanket of mucus. And the top layer of the blanket is next to the air that's passing by it. And in this case, happens to be a lot of cigarette smoke. But that cigarette smoke is touching what layer of the mucus blanket? It has two layers. The gel layer is the one closest to the air that traps all the particles, right? And then the
Soul layer.
soul layer. Mucus blanket has two layers, the gel layer and the soul layer. The soul layer extends, the cilia extend up into the soul layer, remember? And they beat. And as they push the gel layer on up the escalator, mucociliary escalator. And the gel layer is right there at the air that's touching the air. So as you breathe, any kind of particles you breathe gets trapped on the gel layer so that they can move back up so you can cough it up and cough it out, right? But when you have cigarette smoke all the time, that's on your mucus blanket. Look at that. The cigarette smoking is what's causing the chronic bronchitis, okay? It's causing chronic bronchitis. It's also paralyzing these cilia. Cigarette smoking paralyzes the cilia, remember? Right? It paralyzes them. That's why you start coughing in the morning, because at night they stop smoking while they sleep. If you're asleep, you're not smoking. So then the cilia wake back up once you stop smoking, because you smoke all day long. Then when you finally go to sleep, the cilia say, thank you, and wake up and start getting that stuff out, right? Starts beating, the escalator turns back on and starts going and pushing and pushing. And when you wake up, it's right there. That's why they wake up and have a smoker's cough, because they wake up in the morning and cough a lot, right? Because that's all that stuff has been built up to the top because you were sleeping, right? But then once you cough it all up, grab a cigarette, paralyze them again for the rest of the day, okay? So that's stuff you got to know, guys. All right. So that's chronic bronchitis. Not only smoking, but having infections all the time. Exposure for where you work, right? You could work and be smelling something, some kind of inhalant that's causing you to have bronchitis, right? It's inflammation of the bronchi, okay? And then air pollution. So a lot of people in poor areas can have bronchitis because of the air pollution. The factories and stuff like that are usually in poor neighborhoods, okay? You don't see a factory with smokestacks in Germantown, okay? The factories and the smokestacks and all of those type of chemical plants and President's Island, all that stuff is downtown. It's going to be in a poor neighborhood, all right, or in a rural area in the country, okay? They might throw some kind of factory out there in a rural area and have rural children sick, okay? Chronic bronchitis, how does it manifest? Manifestations: bronchial mucus gland hypertrophy and hyperplasia. Thick, increased gray sputum. That's the number one thing right there. Gray, thick sputum. Anybody who's coughing a lot and coughing up thick gray sputum, that's chronic bronchitis. That's how you know it. Manifestations are saying, how do I know it's bronchitis? Okay. Well, if you cough up a nice hoggy amount of thick gray sputum, it's probably bronchitis. Nagging morning cough. Right? Increased infections, always on antibiotics every other month, right? Chest x-ray shows dirty lungs. We call dirty lungs. Just you won't really know that part. The main thing will be thick gray sputum, morning cough. Now, Polycythemia. What is polycythemia? It does. Polycythemia. Look it up on your phone. Tell me what polycythemia is. Because polycythemia will be seen with a lot of COPD patients. They seem to have polycythemia. That's one of the test questions. I remember hearing that about. All these things might be present with COPD, and polycythemia is one of them. Yep.
Yeah, that's what I'm thinking.
There you go. High count of red blood cell. A high red blood cell count. It's called polycythemia. For some reason, that's seen in your COPD patients. Not only just chronic bronchitis, but all of them. All of the COPD diseases. Let's look at the PFT. What do I expect to see on the PFT? I expect to see a decrease forced expiratory volumes. FEVs is forced expiratory volume. So if they can't get the air out, it's going to be low, right? If somebody has COPD, their expiratory volume is going to be low. The forced expiratory, that means how much do they actually blow out? Remember we talked about pre and post yesterday with our peak flow meter, right? That's a forced expiratory volume, forced vital capacity, forced expiratory volume, same thing. And when I'm blowing out, I should be able to move a certain amount. But if I have chronic bronchitis or if I have COPD, which is an obstruction, then I'm not going to be able to get that much out, right? And so my forced expiratory volumes will be low. That's what I expect to see on a PFT, okay? Decreased forced expiratory volumes. All right, so that nagging morning cough. So the doctor says he told him he got a morning nagging cough. He got chronic bronchitis. He said, do you have any other nagging pains? He pointed at his wife. All right. Treatment. How do we treat chronic bronchitis? Well, we treat it with, first thing we do is get you out of the irritants. Remove you from whether it's pollution, whether it's your job exposure or smoking. Stop smoking. Stop smoking. Now, the chronic bronchitis will stop coming if you stop smoking. But whatever damage you do to your lungs because of it, it ain't going nowhere. Okay? So that's what we mean by reversible or treatable. We can stop the chronic bronchitis from coming, but the damage that you do to your lungs because of it is irreversible. Okay? So we remove you from the irritants. And then what? The gold guidelines for managing COPD. What's the gold standard? Early pulmonary function test. That's the gold guidelines for managing COPD. So we treat chronic bronchitis with that. We get you out of the irritant. We give you SABAs and LABAs. What do you think those are? No, you almost had it. It's the same thing, but it's
mild something and long acting bronchos, dilators or something like that.
What else in the D at?
I don't know how to say it.
Short-acting beta agonist and long-acting beta agonist. Okay, that's what that means. Beta 2, right? That's what we're trying to do. Beta 2 gives us what? Bronchodilation. So we give them short-acting beta agonists and long-acting beta agonists. That's another way we treat them. Short-acting will be the what? Which one will be the short-acting? Which ones? Give me one of short-acting.
Albuterol.
Isoproterenol, okay. Another one? Isoethylene. Albuterol. Levoalbuterol. What else? Metoprolol. All of those, right? All of those short-acting. Those are the rescue medicines. Huh? Adrenergic bronchodilator. Yes, ma'am. the short acting. Those are the ones, those specific ones that y'all learned first. Those are the ones that work now. Okay, those are the rescue drugs. Then the long acting beta agonists. Give me one of those. No. That's the steroid. And I'm looking for salmeterol. Yeah, salmeterol. Salmeterol is a long acting bronchoagonist. Now we may add that one with a no, it is a bronchodilator. We might add the salmeterol, which is a long acting beta agonist, and mix it with a steroid, right? And we get stuff like Advair, those kind of dry powder inhalers. That's mixed like that, right? But short-acting beta agonist and long-acting beta agonist is part of the treatment. Okay, Atrovent is not a beta agonist, right? It's an anticholinergic. All right, so don't get that one mixed up. Now they do take those medicines. They will be getting duonib, okay, because it just keeps them from constricting. But as far as the basic way we treat them with sabas and labas, okay. Not only that, but we give them steroids. Steroids. So some of the corticosteroids are inhaled are Pulmicort, right? The Asthmacort, Flovent. You might see Symbicort, stuff like that. Those are your inhaled corticosteroids. That's what they're talking about. And they may even take a pill steroid, which is prednisone, right? Prednisone. All right, might even give them Decadron. Okay, might even do that. Antibiotics, right? Because it says chronic bronchitis always has an infection, some type of upper respiratory infection, right? So give me an antibiotic I might give them as a respiratory. Gentamicin or, it's only two, gentamicin or
tobramycin.
Gentamicin or tobramycin. Those are two antibiotic respiratory medicines we give, right? Oxygen, of course. Might give them a little oxygen, right? Mucolytics, right? Mucolytics. What kind of mucolytics? What's a mucolytic?
Dornase alpha.
Dornase alpha is a mucolytic. Acetylcysteine, which is mucomyst, right? Mm-hmm.
Oxyribose something.
Yeah, Dornavac. Yeah, deoxyribonuclease, which is Dornavac. She said Dornase alpha. Yeah. Mm-hmm. Or even even if we try to hypersaline, right? Hypersaline, stuff like that. Good. Then we might even give them a diuretic, which is your Lasix. Okay, we don't give them that, but the nurses would give them Lasix. Then we treat them with bronchial hygiene. And that's your pulmonary drainage, postural drainage, CPT, airway clearance devices, all that stuff. See all this stuff that's going on with it. Just have COPD. All this stuff is what they do every day. Stop smoking. If you're smoking, stop. It's leading to this. I'm telling you. All right, this is what you're leading to. Now, this is just a little. You don't have to memorize the stages, but like mild COPD. You have your FVC is greater than 80% predicted, right? And then moderate, you have a FVC less than 70%, then less than 30%, then very severe is predicted plus chronic respiratory. I mean, it just gets worse and worse and worse, okay? To start off, we might give little sabas and labas if needed when it's mild, right? Then we might have to give them the regular treatment with one or more long-acting bronchodilators and some rehab. And then it gets worse. We might have to start adding some inhaled glucocorticosteroids if you keep on having exacerbations. And then long-term, you got to give them oxygen and even consider surgery. Okay, you might have to give them a new lung, and that ain't happening. Okay, very rarely will that happen. That's chronic bronchitis. Next one, emphysema. Emphysema is the next COPD disease, C-babe disease. Emphysema. Emphysema is also known as, no, emphysema is
Floppy lungs.
floppy lungs. Floppy lungs. Floppy lungs. Emphysema, I'm going to be kind of crude right here, but think of emphysema lungs like scrotums. Okay? It's like two scrotums with a left and right main stem bronchus in it. Okay? That's what it's like. Floppy, flaccid, right? No snapback at all. Okay, it's just there. Like the back meat of your elbow. You know, somebody my size, if you lock your elbow out, that little meat of your elbow meat, it's just, that's how the lung is. It's just floppy. Old draws. Remember I said old draws. They don't have the snapback anymore. They don't have their elastance anymore. Okay? Emphysema, condition characterized by abnormal permanent enlargement of the air spaces. The alveoli have been stretched and they just stay stretched. Okay? Also accompanied by destruction of the walls of the air spaces without fibrosis. What's the number one cause of floppy lung? Smoking. Smoking. You okay, Kayla? Oh, okay. Long-standing obstructive disease, especially asthma and chronic bronchitis. So not only smoking, somebody can have emphysema and never smoked. But if they have chronic bronchitis or asthma for years, that damage can lead to emphysema, okay? Because that asthma being what it's doing, and then the bronchitis is happening with the infections and stuff going on, it's damaging the alveoli, and they're permanently enlarged. They stretch and stay enlarged, and they don't have snapback anymore. That can cause emphysema. Outdoor air pollution, again, poor neighborhoods or rural neighborhoods might be exposed to outdoor air pollution. All right, that's why these presidents are trying to curb this fossil fuels burning, all this kind of stuff that these factories are doing, and stuff is arriving at your doorstep, but at what cost, right? At what cost? What about your great grandbabies? Are they going to be able to breathe? Will they have to have an oxygen mask on just to live? Okay, because once you destroy Earth, where you going to go? Can't go to another country if Earth is jacked up. Earth is jacked up, you on Earth. You got to leave Earth to breathe. Okay? So, yeah, well, how you going to get there?
They got 18, I think it's 15 super Earth.
But you got to be able to get there, and guess what? The poor folk who started it from the get-go ain't going to get there. All right? Or it can be genetic. Emphysema is also genetic. And that is genetic emphysema, which is caused by the reduced level of alpha-1 antitrypsin. Alpha-1 antitrypsin, AAT. If you're born with a low level of that protein, then it can lead to emphysema. Alpha-1 antitrypsin can cause the lungs to lose their elasticity if you don't have that, okay? So, of course, common sense will say, well, what if I give them some, right? You're right. If it's genetic, it can be treated with IV antitrypsin. Okay? All right, so those are the causes of emphysema. But emphysema is two different types. You have panlobar or centrilobar. Panlobar is alveolar enlargement, usually occurs in the lung bases, and is the most severe form of emphysema. And it's usually caused by the alpha-1 antitrypsin deficiency. Panlobar, which is the worst one, right? The whole pan is nasty, right? You can say, well, I was cooking, but everything I cooked on this side of the pan is all right. But when it's panlobar, everything in the pan is jacked up. The worst one. Panlobar is the worst. There it is right there. Panlobar emphysema is the worst one. And it's usually caused by what? No. There you go. The decreased levels of the protein alpha-1 antitrypsin. I like saying that. Alpha-1 antitrypsin. That's usually the cause of the panlobar, right? So that means all of them are like that, all right? usually in the lung basis mostly, but the alveoli are enlarged pan. Pan means the whole thing, okay? Like one time I had colitis, right? I thought I had just one section, but they call it pan colitis. I mean, my whole colon was inflamed for whatever, because I have diverticulitis, and I think ate something and it inflamed my whole thing, right? So pan means the whole thing, like pandemic. That means the demic is where? Everywhere, right? Pan, all over. All of the alveoli are stretched open. And that's usually because of the alpha-1 antitrypsin wasn't made at birth, okay? Central lobar is when only pockets of them is doing this, right? It's enlargement of the bronchioles, right? Usually affects the upper portion of the lungs. It's the most common form, and it's caused by smoking and inhaling toxic irritants. So central lobar is less severe, but the most common, okay? It's less severe, but it's most common because of smoking and inhaling toxic irritants. Now, it's good to notice that the panlobar says alveoli are enlarged, and the central lobar says the bronchioles are enlarged, okay? So think about this. The alveoli are attached to the respiratory bronchioles, right? So you have your alveoli are connected to your respiratory bronchioles, right? Well, in panlobar emphysema, the alveoli are stretched and enlarged all over, right? But the bronchioles may be fine. See, look at this right here. Look, y'all look at the PowerPoint. See the bronchioles right here? See how they're normal size right here? But the alveoli that are attached to it are all fat and nasty, right? Okay. Well, in central lobar, the alveoli may be okay, but the bronchiole is way distended. See that? This is the bronchiole right here that's been stretched open. See the smooth muscle? See the smooth muscle? These right here are smooth muscle. Those are so the smooth muscle all the way up through here is stretched, right? The alveoli might be normal size, but the bronchioles are jacked up. Okay, and that's the most common kind from smoking and inhaling toxic chemicals. So emphysema is another COPD disease, which has two types, central lobar and panlobar. Panlobar is the most severe kind, and it's usually the genetic part because of the protein deficiency alpha-1 antitrypsin. And central lobar is the one you get from smoking, okay? Less severe, but most common. You good, Ms. Scott? This one here? Oh, okay. All right. Emphysema, still talking. How do we treat emphysema? Well, of course, quit smoking. Okay, quit smoking. Remove them from the irritants, and it's probably smoking. Also, gold standards. If I know you got emphysema, I need to do a PFT as soon as possible so I can see what level are you, mild, moderate, severe, or very severe COPD. Okay, I need to know. Again, treating with SABA and LABA, steroids, oxygen, diuretics, pulmonary rehab, or I can give them some IV alpha-1 antitrypsin. Right, that's the treatment of emphysema.
What's normal emphysema? What's normal emphysema?
What you mean?
On the side it says A is normal, B is kind of like. Oh, okay.
I don't see what you're talking about.
This is pictures. Okay, I get it.
Okay. All right. So of course, if it's panlobar, I may even give them some IV alpha-1 antitrypsin, right? Because that's going to help give them that protein that they don't have and help treat the emphysema if it's genetic. All right. So that's the treatment. You'll notice that, guys, the treatment for all of these COPD diseases is about the same, right? You're going to treat it with gold standard. You're going to hit them with the SABAs and LABAs, the steroids, give them oxygen or diuretics if need be, and pulmonary hygiene, okay, and get them out of the area. Asthma. Asthma, and we're almost done. Asthma is primarily an inflammatory disease process with clinical manifestations of airway hyperresponsiveness and airway obstruction, and is partially or completely reversible either spontaneously or with treatment. So asthma is either completely or spontaneously reversible when you give them a breathing treatment, right? But the damage that the asthma is doing is irreversible. Don't get that mixed up. The symptoms, right? The symptoms or the activeness of it is reversible, right? If you have a bronchospasm asthma attack, see you later, asthma attack, I can treat that with a short-acting or long-acting bronchodilator, right? Preferably the short-acting, which are the rescue drugs like albuterol, terbutaline, bronchosol, all of those you learn, levobuterol. Those are your emergent, they start working immediately, okay? The long-acting bronchodilators, they work for a long time, but they take 60 minutes to start. That's a long time, okay? So when asthma attack happens, you want to give them a short-acting bronchodilator that opens them up right now, okay?
Is there I guess a preventative drug that asthma participate? So my son had asthma and bronchitis when he
Yeah,
was
y'all
little.
you just had that on the test. What's the drug we do for prophylactic for asthma? Chromium sodium is one. Needle-chromium sodium.
I didn't know it was preventative.
Yeah, that's the only reason we give chromium sodium. It is prophylactic for asthma.
I thought it was okay.
Yes, prophylactic for asthma. We're going to try to prevent you from having it. It's going to coat the mast cells so that those irritants that come in, whatever your cause for asthma is, can't get into open up the door for the prison, because histamine is just waiting to get out. And so when that pet dander, if that's what triggers you, it comes and breaks the door open, and the histamine gets out, causes a problem, right? Or if it's pet dander, pollen, certain smells that people have, little stuff that trigger the asthma. If it's intrinsic asthma, then we want to get something that will block it, right? We'll coat the mast cells so those histamines can't get out. If it's extrinsic asthma, that means stress or somebody calls you to have an asthma attack because they scared you and stuff like that. And you can't really treat that one, right? You can treat the symptom, but you can't prevent that, okay? Unless you just stop stressing, right? Or whatever it is that's causing the problem. Aspirin can cause. We're going to see all that here in a minute. But yeah, the preventive asthma attack, yes, ma'am. So, and as a respiratory therapist, you can go back and become an asthma educator and have that beside your name too, right? Which is more money. And schools will fly you all over the world or all over the country to go teach and talk about asthma, okay? All right. Epidemiology of asthma, which you don't have to remember this part for the test. It's just giving you some information. 25 million Americans, over 20%, 27% affected with asthma are children. Accounts for 25% of all emergency room visits as an asthma attack. 14.2 million outpatient visits, hospitalizations, 3,400 deaths, 56 billion in 2007 for treatment for asthma. So very, very common. Very, very common. It's a very, very lucrative job to be in as a respiratory therapist. Okay. Now, these are the causes. You have allergic causes and you have non-allergic stimuli, okay? Allergic stimuli will be pollen, animal dander, and dust mites. Somebody keep a dirty house, and then it's always, you look at their blinds. To know if somebody got a nasty house, go look at the blinds on the window. If their blinds are nasty, they nasty. Okay, that's just the bottom line. Because if they have a lot of dust on the blinds, there's a lot of dust in that house. Now, they may clean up for you to come, but when you gone, right, they just that lets you know how somebody is. When somebody ain't there, how the room look. Like when you look at your children's room, if it's nasty, right, or if your children's room, they clean it up when they got company, but when they ain't got no company, it's just clothes and stuff everywhere. Now, when I say nasty, guys, I'm not talking about nasty feces type nasty. I'm just talking about when you leave clothes out on the floor. Yeah, trifling. You haven't cleaned out your sink, little stuff like trash, food plates and stuff. That's just trifling, right? But I just say nasty in one box to me, okay? Uh, my house cannot be nasty. Everybody at the house know how I feel about that because it's too much things you can get. All right, so allergic is the dust, okay? Always dust your vents and always dust your blinds, stuff like that. Your top of your entertainment system. Take that little stuff down, pictures of mama down, dust that stuff because that stuff it infects you, okay? Especially if you got a child with asthma, okay? Uh, Animals. Some people can't stand cats or dogs. Just smelling them triggers their asthma, okay? It opens up that mast cell. That dander will go to the mast cell, break it open, and histamine and leukotrienes just fly all through the system. Their eyes get watered up, asthma attack, can't breathe, all of that, okay? Now, non-allergic. So asthma has two types, allergic and non-allergic. The non-allergic stuff, right, it's not because of an allergy, it's just because of your exposure. Chemicals, right? Cigarette smoke, cleaning agents. Somebody has some bleach, it was real strong, but ooh, trigger you. Are you working in the hospital? They got some strong cleaning things we use. So if you got sensitive airways, you need to be mindful of that. You might have some patients, some workers have to be, I can't be on that floor. They're stripping or waxing that floor on 3. I can't do 3. Switch 3 with me because if I go to 3, I'm gonna have an asthma attack, right? You do that with your fellow colleagues. Taking aspirin. Aspirin can trigger an asthma attack. I don't know why, but it does. Chest infections, if you got some type of infection. Stress, right? Stress can cause an asthma attack. Laughter, you were laughing so hard that you had a bronchospasm, okay? Cold air, that hawk, you breathe that hawk and your house is 85 degrees and all, you know how some folks like it hot in their house and then they get ready to go to work and hit that door and take that first breath and it's really cold, they can close that airway up, right? Be careful. Exercise can cause it. And preservatives, eating those ramen noodles and those cold cuts, those highly processed food, right? Preservatives and processed food, canned food, stuff like that can cause can cause asthma in adults. How does it manifest? Partially or completely reversible airway bronchoconstriction. It manifests as respiratory distress, shortness of breath, diaphoresis. What's diaphoresis mean? What's diaphoresis? Miss Rose, you know what diaphoresis is?
Is it constriction of the diaphragm?
No. Miss Woods?
Does that have to do with blood pressure?
No.
Sweating?
Who's that?
Sweating?
Sweating, profuse sweating. Diaphoresis is profuse sweating. You sitting somewhere and you look around at somebody and they just pouring sweat. Like, damn, what's wrong with you? Right? Heart attack. Somebody who's having a heart attack will break out into a massive sweat. Okay, that's called diaphoresis. So somebody's short of breath, they're nervous, they can't breathe, they're sweating, the cough is weak, right? Why is the cough weak? Because you can't get no air out. If you can't exhale, you can't cough. You got to have a good vital capacity in order to facilitate a cough. Remember we said that? Vital capacity must be adequate to produce a cough. All right, so that's weak cough and cyanosis. What's that? Cyanosis. What's cyanosis? Cyanosis. What is cyanosis? What you say?
They appear
blue. Blue color. Remember when you're short of breath, oxygen is low, cyanotic. Cyanotic. The hands get blue, lips be blue. Cyan. Cyan means blue. Blue color. Cyanosis. This kind of stuff you got to be able to look at when you're looking at the patient. This is what's going on. I note that, he's diaphoretic, he's has dyspnea, very weak cough, and his sac got to be low, right? Because I see his lips are turning blue. Baby's lips turning blue, feet turning blue. Y'all got to be able to see this immediately and fix it. You're going to lose that child, okay? They drop hard, they drop fast. Increased mucus glands causing thick secretions, Wheezing, right? They wheezing. Shortness of breath, chest tightness, and cough. These are all things that happen with asthma. Okay. If you look right here, these are your airways. They're talking about the small, smooth muscle airways right here. So you look at this little spot right here. Let me see. Let me get my pointer. See this little section right here that's showing you the airways, right? This is it right here. It should look like this. Nice and normal, smooth, clear, no mess in there, right? Nice and fluid. Normal airway, okay? Normal airway wall right here. But then look, during an asthma, you have the airway has now been narrow because this is inflamed. The wall is inflamed. Look at this. This is inflammation right here. It's swelling. It's swelled up and it's inflamed. Now the airway is small, and what's in the airway? Mucus, right? So not only do I have tightened muscles, right, that make the airways constrict, right? These smooth muscles right here get tight. That's what the airway itself doesn't do anything. The smooth muscle is what contracts, right? Bronchial smooth muscles. When we have beta-2 agonists, they dilate the bronchial smooth muscle. This is the muscle right here. Look at your picture. This is muscle. This is muscle. This is muscle. And this is muscle. It's like little fingers over your, fingers, right? These will be the muscles. And then squeeze that airway shut, right? If this is my airway, guys, can y'all see the picture on? Okay, if this is my airway, of course, and these will be my muscles. My fingers will be the airway smooth muscle. And they just land on there just like this. And as long as they're open, they're fine. But when an asthma attack happens, they squeeze or constrict, right? Now, I'll take a beta agonist that will open the smooth muscle, which then will open the airway, okay? The smooth muscle is what contracts or dilates, not the airway, all right? But you might as well be the airway because they're wrapped all the way around them, right? And so when you have an asthma attack, these bronchial smooth muscles constrict. And look, see how they like finger lines, right? It's just squeezing it tight. And now there's mucus and stuff in there. So just look at the wall. Now look at the wall. It's very constricted, right? That's when you need to use albuterol right now. So that's going to go back to this and more because this is normal, but we want dilation, right? Don't forget there is bronchodilation, constriction, or normal tone, right? This is constriction, right? See these muscles, see them lines right there? Those are the bronchial smooth muscles right there. See how it's got that dip because it's squeezed down. And I thought I saw my other one somewhere. All right, well, this will be normal tone here. This is normal tone. Smooth muscle, see it's less of a dip. See that? See how much less of a dip this is? They're not squeezing, right? And then I don't know what oh, here it is. And then my bronchodilation will be this one. And see, dilation is even less of a dip than normal, right? So not only is it not normal, it's opened up some. And now it's pretty much flat across there because it's like that and made that airway open up. So, that's all right. Yes. So when the muscles constrict, you get that airway, that dander or whatever that causes these bands right here. These bands, which are the muscles, squeeze down, right, and make that airway narrow. See my mucus? And you got mucus in there. See that mucus, right? And so not only do you have mucus in there, but you have less space, and now you hear wheezes, shortness of breath, because they can't breathe. So then I want a short-acting beta agonist that will dilate me just like that. I breathe that albuterol in, that terbutaline sulfate, the metaproterenol, bronchosol, levoalbuterol, right? Breathe those in, and this is what's going to happen. Boom, dilate. And after the dilation, phosphodiesterase will break the 3,5 down to 5 and go back to normal. Okay? All about the muscle. Okay? It's all about the muscle. What happens to the muscle when you use those drugs? Okay? So that's asthma. All right, it's manifestations. Now, diagnosis, asthma diagnosis. we usually look at the past symptoms, right? Shortness of breath, wheezing, coughing. We ask about that. Family history. Asthma can be genetic, okay? So if mama got asthma and daddy got asthma, then that helps us diagnose it, because a lot of things can look like asthma, all right? We have to kind of differentiate between something else and asthma, all right? And so if you're looking at the family history, also look at this, eczema. Did you know eczema goes hand in hand with asthma? Usually a baby or child that has bad eczema also has asthma.
Oh, you know what? My
Okay.
daughter. My daughter has both.
Yep.
Yeah, asthma and
And eczema, they go hand in hand. I don't know, just some type of, I don't know. That's when you become an asthma educator and you can tell me. Nasal polyps and aspirin intolerance. Patient can't take asthma. If they got somebody in the history who can't take aspirin, that's probably, you probably got asthma too. All right. Chest x-ray. Now, a chest x-ray cannot say asthma. It just helps us rule out other things, right? A chest x-ray will help me rule out bronchiectasis or bronchiolitis, right? It helps me rule those out. If it ain't that, then it's got to be asthma, right? See, chest x-ray to rule out other causes of this problem, right? PFT. PFT will show me whether you have an asthma or obstructive problem, right? And bronchoprovocation, I forgot what that was, but don't worry about that. I'll look it up. I forgot. All right, classification. You don't have to remember the classifications, but this is for you to look at if you want to. Just kind of talks about if somebody has a classification of asthma severity in use that are less or greater than 12 years of age and adults. Okay, so 12 and up. Intermittent, you have symptoms less than 2 days a week, right? If it's mild, you have symptoms more than 2 days a week, but not daily, right? Moderate, every day you're having some symptoms. And then severe, all day, every day. That's severe, okay? Then those nighttime awakenings, short-acting beta agonist use for symptom control. If it's intermittent, then you're using those sabas less than 2 days a week. You know, you barely have to use your little inhaler. If it's mild, you're using them more than 2 days a week, but not every day, okay? Not once a day. If it's moderate, you're using your inhaler every day. Okay, you're having to use your inhaler every day. And if it's severe, you're using that inhaler several times a day. Okay, so this is just kind of helps you understand the severity classification of asthma. All right, but what we'll talk about is lung function, right? If it's intermittent, then our FEV, which is forced expiratory volume, that one means in the first second, right? Because they're going to tell you to take deep breath in and blow, 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 keep on, keep on, keep on, keep on, you know, a couple of seconds. But the computer is going to measure how much went by in that first second and then how much went by in the rest of the time. FEV1 is the most you can blow out in that first second, how much comes out, right? Based on your age and your height, what it should be, and they're going to give you a percentage of where you are, okay? So FEV1 is normal between exacerbation. If you ain't having an exacerbation means a flare-up of something, right? If you got COPD and if it's, you know, you got cold outside or got a cold, now it's worse, right? It's an exacerbation. Or if you always have acid reflux, but then today you just, throwing up and it's just an exacerbation, right? Exacerbation means a flare-up of that certain disease, okay? So they're saying between exacerbations, your FEV is okay. That's pretty normal, right? If it's just intermittent, it's mild. The FEV is greater than 80% predicted. So you blow out, it's 80% or better, right? And the FEV1 and FVC is normal, all right? Now, what if it's mild? Well, let's not do mild, let's do severe. If you have severe, your FEV is less than 60% of what you should be doing, right? And so that is real bad. That's letting you know you have real bad asthma. I blow into that and I'm less than 60% of what I should be. That's less than half, right? That's very bad. All right. How do we, I forgot that. Status asthmaticus, make sure you highlight this. Status asthmaticus is a special type of asthma attack. And I ain't doing no breaks because I'm trying to go and get through and then you can go, okay? Unless you need a break. Status, huh?
No,
Oh. Status asthmaticus is a special type of asthma, not just a regular asthma attack. A regular asthma attack's scary, and you take some medicine, and you know eventually you be all right, okay? But status asthmaticus is an acute exacerbation of asthma that does not respond to conventional therapy. You gave them medicine, it did not work. It means it's, what does that mean? If something doesn't respond to it, what's that called? What's that word called? Just like we said, if you don't respond, your sats don't go up when I give you oxygen. Uncorrected, but there's a certain term. When somebody's condition won't respond to the oxygen I'm giving it, that means it's, huh?
Tolerance.
No, not tolerance, but that's a good thought. But there's a certain word came back from a couple of units ago when we talk about when something doesn't respond to a therapy, it is what to that therapy? Starts with an F. I mean, starts with an R. Starts with an R. This asthma attack does not respond to conventional therapy. That means it is what to conventional therapy?
Restrictive?
Not restrictive, not resistant, but refractory. Remember that? Refractory. Some conditions are refractory to oxygen, right? We give oxygen, but it don't do nothing. It doesn't help them, right? For this case, somebody who's suffering from status asthmaticus is refractory to conventional therapy. We gave them albuterol, we gave them a long out, we gave them steroid, we gave them all those things, but it's refractory. It's not responding to it. It does not respond to it. That's refractory. Don't forget that. That's very important because you have some patients that are refractive to certain things. You got to do something else. Okay. If you know somebody is refractive to just oxygen therapy, then don't keep trying to give them oxygen. You need to be doing something else. Okay. You need to be adding some PEEP, stuff like that, which you'll learn later. All right. Patients with little or no warning and rapid deterioration just hit you. Status asthmaticus can hit you with little warning, right? And you drop rapidly. Rapid deterioration means you go down hard and fast, and we're gonna have to probably intubate you. Somebody with status asthmaticus may have to be intubated or put on a CPAP machine or something, BiPAP machine to help blow some air in there, because the regular conventional therapy. What is the conventional therapy? Sabas and labas, steroids, right? Get them away from the irritants. Those are the standard things, right? But that ain't working for him. That's called status asthmaticus. A little bit different, way more severe. 85% of the deaths had an episode lasting more than 12 hours. So somebody may have status asthmaticus for 12 hours. So after they have it for 12 hours or more, 85% of them die. Okay, so you need to get them fixed, right? You need to figure out, okay, I gave him this, but he's refractory. So I need to do something else, right? It's time to intubate this patient. It's time to put him to sleep and breathe for him. Otherwise, you're gonna lose him. Okay. Most common, severe bronchospasm with mucus plugging leading to asphyxia. See, once this bronchoconstriction, this is it right here. Status asthmaticus. If you don't open this up, he's gonna die of asphyxia. Right? Asphyxia is lack of oxygen to the brain. That's asphyxia. If I sit here and choke you right now, I'm gonna cut off your oxygen to your brain. You're gonna die of strangulation. That's asphyxia. Okay? That's just. Or what about if I put a plastic bag over your head and tie it up? You're gonna die of asphyxia, right? Because you can't get no air in. That's why we tell you kids not to play with plastic bags. Don't let your children play with plastic bags, huh? Suffocation, same thing. Asphyxiation and suffocation is the same thing. That's why we tell your kids, don't let your kids play with them little Kroger bags and running around and doing that. Because if they mess around and get it on their head and can't get it off, they're gonna die. They're gonna die if you're not around. Okay. All right. Signs of status asthmaticus, and we're almost done. There's only a few left. Breathlessness at rest. He just resting and can't breathe. He just sitting there and can't breathe, right? Unable to speak in full sentences. Wheezing during inhalation and exhalation. The peak expiratory flow is less than 50% of personal best and does not improve. And pulseless paradoxis. Pulseless paradoxis is a difference in your pulse. If you're feeling your radial pulse and it feels different when you breathe in, they take a breath in and it slows down. That's something wrong with that. That's called pulseless paradoxis. It's not the same. It should be the same when you inhale and exhale. Pulse shouldn't change, but it changes between exhale and inhale. That's pulseless paradoxis. Okay. This is status as asthmaticus. That's why asthma can be so bad, because anybody could have a severe asthma attack or go into status asthmaticus. Okay. All right. How do we manage it? Well, of course, the other stuff we manage, but this is something special. Regular doctor visits, of course, and have an action plan. Now, spirometry that we're talking about, the peak expiratory flows, peak expiratory flows, that peak flow machine I showed you. All right. It's going to have an amount from based on your height and your age. Remember, I showed you that yesterday, and you should be able to blow into it one time and it kicks up. Okay. Well, what you do is the stoplight method. Okay. Your worst one, you do it like 3 times. Your worst one, you put the red, you slide some of them are color coded. You slide the red one to it. And then the best one, you slide the green one to it. And then you want to at least stay in between the red and the green. Okay. That's what you're doing. Okay. And so I got to use the bathroom anyway. I'm going to pause. Okay, guys, we got back from the break. We're talking about asthma management and how do we manage it? What kind of action plan can we use for asthma? And we usually use the stoplight method, okay? Objective measurements and monitoring of lung function like spirometry and peak flow readings, home peak flow readings, the use of the stoplight method. Here's the stoplight method right here. Green is 80 to 100% of percent predicted, okay? Patient is having no symptoms, and medication can be continued or just tapered, right? You're barely using your medicines, right? You don't have no symptoms. You blew into the machine and you're 80% of where you should be, 80 to 100%. Yellow zone would be your 61 to 79% of where you should be. Peak flow rate, peak expiratory flow rate, okay? You may be having an acute exacerbation, right? You might be having a little acute exacerbation, temporary setup in treatment, right? So you might have to set up and get you a little treatment. All right. Now, red, if you blow into your peak flow meter and you're at the red, well, then that means you are less than 60% of your peak expiratory flow rate, and that requires immediate medical attention if the short-acting beta agonist drugs don't return you to the yellow or green, okay? So this is what it looks like. This is what that looks like. All right, here we go. So this is what this looks like. I'll take this off. Nobody's in here anyway. All right. Now, this is a good one to show you. Look at this one. This is then several types of your peak flow meters, right? This is one type of peak expiratory flow meter. Remember, we do this pre and post breathing treatment, okay? But if you have one at home, you can test yourself. You're feeling a little bad or you're not sure, do it. See where you are, right? This is good to do if you wanted to do education at your church. Get a hospital to donate you a bunch of these, or sometimes they look like this or whatever. Or the ones I showed you yesterday, the little cheap peak flow readers, right? But the church or something like that, or a hospital would donate them to your church, and they love to say that because they say they donated to Greater Zion CME Church, whatever, and they like to say that. And then you can use that with your health ministry and say, okay, I want everybody to give everybody one, and then teach them on it and measure them. And because they might say, you know what, I never knew I was only 50% of where I should be. Maybe I'll look into that. and find out they have COPD or asthma or something like that, start getting treatments, and you have prevented possibly an asthma attack, okay? You can do this at daycares and tell a daycare, hey, you pay me, I'll come out and test all of your children for their peak flows to see where they are, and do one, send that, make a report about it and send it home with the child, right? And the parent will say, oh, I like that daycare. That daycare has a respiratory therapist on deck that watches and makes sure our children our rates are right? So stuff like that is a lot of little ways you can make money on your own, okay? So this is the stoplight method of the peak flow reading, okay? Notice it has the green, yellow, and red, okay? Now, this meter here will go up when I blow it, when you blow it, right? It'll go up to wherever number that you are, okay? Now, the numbers are based on your height and your age, okay? And like, these are older, so I don't have the pamphlet in here that tells me what it should be for each one or whatever, okay? But you can look it up online. All you have to do is type in peak expiratory flow rate calculator, right? Peak expiratory flow calculator. And they'll tell you to type in your height or whatever and your age, and it'll tell you where you should be, all right? But for us teaching purposes, you would do 3 blows, okay? Your best one, you put the green one there. Your worst one, you put the red one there. And you want to at least be in between the green and the red, okay? So what did the stoplight method say? The stoplight method said that if it's green, if I blow into it and I'm up at my green, then I'm 80 to 100% of my peak expiratory flow reading, right? No symptoms. Medication can either be continued or tapered, right? Just taper it. Yellow, I'm at 61 to 79% of my predicted flow, and red, I'm less than 60%. So this requires immediate attention. I need to go take a breathing treatment, right? And go get medical attention if that breathing treatment does not work. If I do the breathing treatment and I blow again and I'm still in the red, I need to go to the doctor. I need to say, look, it's impending. It's sooner or later, I may have an asthma attack, okay? And so this is how we manage, or how we allow the patient to manage their own function from home, okay? This one is like this. This is a cool one. You just kind of hold it like this, put your finger in it, right? Hold it with your finger in it, and you would blow. Of course, I have the little meter right here, right? Just the pocket peak. It's called the pocket peak. I don't know if you can see that. Inspire pocket peak, little cute little peak flow reading, right? And then, like I say, these will move up and down to wherever it needs to be moved to. So what I'm gonna do is I'm gonna show you a breath. I'm gonna take a deep breath in and blow it, and it's gonna show you. Right now, it's showing at 0, right? Or less than 50, yeah. So that's around 0. One breath. Shot me.
I thought I was gonna come back down. Like, how you supposed to catch it?
Oh yeah. So you saw mine went up here to about 410, right? About 410. That's pretty good for my height, right? Okay, so my green is up in here. So let me do it again. Right? The next one was about 350. All right. And then I'll do it again. You bring the blue one back down and you do it again. All right, and this one was about a little less than 4. So my best was about 450, and my worst was 350. So my worst was 350. So that's how mine would look, right? My best was around 450. My worst was around 350, and so the yellow will be in the middle, okay? So it works better, especially knowing if you know where you're supposed to be, okay? So that's first. Make sure you look at the thing and tells you, or you can, like I say, go online and Google and just type in peak flow calculator, right? And it'll pop up a little thing to show you to put your age in and your height, and it'll tell you you should be at such and such and such, okay? All right, so then when you do that, where it tells you where you should be, that's where you put your green, okay? If they tell you that you should be at 500, then you put your green to 500. And then you do your 3 times and see what your lowest one is, and you put that at the red, right? And your yellow should be in the middle. That way you know you are at least where you should be. If you don't know where you should be, you just do what I did 3 times and do my best and my worst. Because I don't have any symptoms, I feel fine. So it must be where I'm about where I should be, okay? But don't just guess. Always go online and find out, okay? When you open up these, they will have a little thing in there, but see, we don't have any new ones. This has been here since 2004, I'm sure. And so, you know, I have no way of knowing where I should be. I forgot where I'm supposed to be. But this one comes like this. So that was this one. And this is this one. This is the personal best. It's called the personal best peak flow reader. You just open it up like that. And this is it. See that? Boom. You got your green, your green and yellow and your red, and you know the yellows match with each other. And this little thing here will move when you blow. Okay, so you take this in and take a deep breath in there, boom, blow 1 time, and the little red meter will go up. Of course, do the same thing I just showed you with your green and your red. All right. So if your patient or you, if you got asthma or whatever, and you know where you should be, and you're constantly blowing. So say you're constantly blowing, and you are like this, that needs medical attention, okay? If you're feeling kind of funny or not feeling strong as you should be, and you know that you're supposed to be at 4 or 500, right? That green goes over to the 500, right? And you are down and your red is like 350, but you're down at 300, then you're less than 60% of where you should be. You're in the red. Go take a breathing treatment. If that breathing treatment doesn't work, you need to go be seeing call your doctor, get an appointment, see what's going on before something happens, okay? Make sure your MDI's in your pocket, in your purse, wherever, where you can get to it if you need to, because you are not where you should be. And this is also good because if you do some children at a daycare, right? Parent might not even know his baby she got asthma, right? Not yet, right? But you're doing this and you say, hey, I did a peak flow reading on your child today. I'm a respiratory therapist, RRT, and I'm doing some things at the daycare and for free, right? I'm just doing to show you that your child is way less than where he or she should be. You might want to look into that, right? And then the doctor can do a PFT on them and say, yeah, he is. I'm glad y'all found out, because this was going to lead to an asthma attack that he may or may not recover from, okay? So that's doing a service to your patrons, right? To your community, to people that you care about. And not only that, if a daycare wants to hire you to be on staff like that, they can advertise. We got a respiratory therapist that sees our children monthly or weekly or whatever to test them, right? Because most things that happen in a daycare would be respiratory issues. Yeah, they throw up and stuff like that, but mostly it's asthma, some type of upper respiratory infection, you know, stuff like that. They have running, all that kind of stuff that you deal with, all right? And so that's just good things for them. And like I said, this was the other one I showed you from yesterday. This doesn't have the colors in it. You just have to kind of know. This is a little bit cheaper, right? But it's the same thing. That's how we manage asthma, okay? So I did mine. If you would like, you can. I got another one here if you want to. You can do this one. Now, this also is an old one. This is an old school one here, right? And I will put this doesn't really fit good, but put that on there right there, and this will go up, right? This little starts at 0, and this is called the assess. This is called the assess peak flow meter, okay? Clear, so you're not gonna have one of these in your purse, okay? But I would take a deep breath in, right? Went up to about 350, right? Like my other one did. Now this doesn't have good, see, it's not a good as a seal as that one, but if you hold it on there tight, you get a pretty good seal. All right, around 350. So that's about where I'm at, right? That's about where I'm at. That first one gonna be good, but after you keep doing it, you know, it's gonna go down and tire yourself out. But that's it. So if, like I said, if you want to, you got a brand new one here. You can try this one or this one, okay? All right, so that's our peak flow. That's how we measure or manage asthma. Okay, one way that we manage asthma. All right, we'll go back to it. We're almost done. All right, asthma treatment. Again, this is just another factoid for you to go back and look at. This is not testable stuff. All right, treatment and prognosis of asthma. Of course, we're going to treat them with pharmacologic therapy. That's breathing treatments, right? Remove them or minimize the triggers, because you may not can always remove somebody from stress, but you try to minimize it if you can. Education and control. Control is the best treatment for asthma. So if you get a test question, what's the best treatment for asthma? It's control, okay? Controlling it. A lot of children will grow out of it. You know what I'm saying? As they get older, their bronchioles get a little bigger and more developed. They grow out of it, okay? But the best treatment is control. Prognosis, huh?
My son grew out of it, but it was after they did like treatment of steroids.
Mm-hmm.
They did they kept on doing the albuterol.
Mm-hmm.
It would never work. He had blood inhaling stuff. So as soon as they put him on steroids for a period of time,
Mm-hmm.
I guess it strengthened up his lungs, and he was fine after that.
Yeah,
No more asthma.
because remember that steroids are used for
Inflammation.
inflammation. Yeah, inflammation. So a lot of asthma can be in conjunction with inflammation. So prophylactic medicine for just asthma was chromium sodium. But if they have a inflammation issue with their asthma, then prophylactic we give them neochromium sodium. That's the difference between the two. Chromium is just for straight up preventative of asthma, and neochromium sodium, remember, is asthma and inflammation. Okay, and so prognosis is childhood asthma generally improves. The severity of the disease may be indicative of lung damage. Okay, and it may lead, to COPD. So asthma over and over again, having these attacks, damaging the lungs, could then eventually cause you to have COPD, right? Because then you got asthma and emphysema, right? Or asthma and chronic bronchitis. Those two together, now you have COPD, all right? Bronchiectasis. Bronchiectasis is chronic dilation of the bronchus or bronchi, usually in the lower portions of the lungs, caused by destructive and inflammatory changes in the airway walls. Bronchiectasis is dilation of a bronchus or bronchi, all right? So don't forget, you have your left and right main stem bronchus, then you have the bronchi. Now, those bronchi should be uniformly the same size, but when they are dilated, that is a sign of bronchiectasis, all right? Now, the causes of bronchiectasis, you have local and diffuse bronchiectasis. So just like you had a couple of different types of emphysema, you have a couple of different types of bronchiectasis. You have either local or diffuse. Local bronchiectasis is one area of the body, right, of the lung. One area of the lung is showing dilation of the bronchus or bronchi. They're dilated in this one little section, maybe like the left upper lobe is showing, the bronchi in the left upper lobe is showing dilation. That will be something that's local, right? And that can be coming from a foreign body. You might have some kind of foreign body trapped in there and making it wide, or an airway tumor is there that's making it be dilated, or external bronchial compression, right? So something on the outside of the bronchi that's pressing against that bronchi that's making it compressed, okay? That's local, all right? Then you have diffuse bronchiectasis, and that is dilation of the bronchi or bronchus all through the lungs, throughout both lungs. That's called diffuse. Now, the things that cause diffuse bronchiectasis is cystic fibrosis. See that? So you see how cystic fibrosis can then lead to dilation of the bronchi, and that's two different things. Now you have bronchiectasis and cystic fibrosis, so now you have COPD, because cystic fibrosis is also one of the C-babe diseases. So you see how these are combined together to make the whole big picture, which is COPD. All right. So just like earlier, we talked about emphysema can be caused by asthma and chronic bronchitis. When you got both of them, it can destroy your lung and make you go into emphysema. Now you have COPD because you have two or more of those C-babe diseases. Well, bronchiectasis can lead to COPD because bronchiectasis can be caused by cystic fibrosis, right? So diffuse bronchiectasis can be caused because you already have cystic fibrosis, which is something you're born with. We're going to learn that next. I think that's the last one, and we're through. But what we're talking about, the causes of bronchiectasis right now. Diffuse bronchiectasis is the one you're going to see the most. It's caused by cystic fibrosis, ciliary mobility disorders, where the cilia can't move, right? Also, alpha-1 antitrypsin deficiency, and infections like tuberculosis, the flu, measles, whooping cough. Those type of infections can cause bronchiectasis. They cause diffuse bronchiectasis, okay? Now, once you see, so I want you to be able to understand it. Now you see how cystic fibrosis, you're born with cystic fibrosis, okay? And it has so bad that it's causing bronchiectasis now. Well, now you got two of the C-babe diseases, so you're classified as COPD, all right? All right, let's look at it. Bronchiectasis is cool. It's cool. It's funny, but it's cool, okay? All right, cylindrical. These are the types of the classifications. You either have cylindrical, cystic, or varicose, right? Varicose, cylindrical, or cystic. Those are the three classifications of the bronchiectasis. What I just showed you earlier was either local or diffuse, okay? That's just talking about where it is. Local means it's right in one little lobe of the lung for whatever reason. Could be some kind of foreign body, a tumor or something in there. But the most type of bronchiectasis is the diffuse. It's throughout both lungs, okay? Now, once I have bronchiectasis throughout both lungs, the bronchiectasis could be one of three different types. Either varicose, cylindrical, or saccular, okay? Now, let's look at it. Cylindrical or tubular, that's the mildest form. The airway wall is uniformly dilated. Now, we said the bronchi is dilated. If the bronchi are dilated, that's bronchiectasis, okay? Bronchiectasis is chronic dilation of the bronchi or of the bronchus or bronchi. Remember we said that, okay? That's what it is. Now, cylindrical is a mild form of it. It means all of the bronchi or whatever are uniformly dilated. They're not, big right here, then skinny, then real big again. They're uniform. They're dilated, but they're uniform, okay? Varicose is the most severe. Varicose, also known as fusiform. Varicose, also known as fusiform, is the worst kind of bronchiectasis you can have, okay? You have thick varicose veins, right? More severe, this is the more severe, I'm sorry. Varicose is more severe than cylindrical, okay? Varicose is more severe than cylindrical, all right? Irregular pattern with alternating areas of constriction and dilation, all right? So let's look at that. Let's look at that so we can make sure you understand what I'm saying. All right. So bronchiectasis, if we're talking about cylindrical, right? You have your bronchi all the same dilation, right? They're dilated. Shouldn't be this big. But they're the same size, right? This is called, what's it called? Cylindrical? Tubular. Okay, tubular, less, yeah, that's the mild. That's the mild. Mild, right? Because bronchiectasis is, this is dilated. They should be like this, right? Should be like that. This is normal. But when they're dilated, look how big this is, right? This is wider. That's dilated. So I'm going to put dilated. Dilated bronchi, okay?
Uniform dilated.
Uniform. Right? Dilated uniformly all the way around, right? Okay? That's the tubular one. All right. Then you have varicose, which is more severe than this one. So this is the first one. Then you have varicose. How you spell that?
V-R-I-C-O-S-E.
Varicose, also known as fusiform, right? Then it is very, right? So you have it like this. So they are dilated and then in like this, right? That's alternating. What did it say? Alternating what?
Irregular pattern of alternating areas of constriction and dilation.
So look, you got constriction and dilation. You got constriction and dilation. Right? This is a bronchial, right? And then you got this one over here. Way big again. Way big again. Right? You got constriction and dilation. That's varicose. All right? Then the third one is what?
Cystic or saccular.
Okay, so how you spell cystic? C-Y-S-T-I-C. Or
Saccular.
they say C-C-U-L-A-R.
Yes.
Cystic or saccular says what?
Airway destruction builds up in sac. Is that what you look for? Dilation.
Like sacs,
Yeah.
right? So the dilation is like this. All right, so you got this one right here, that, right? Then this one. See that? The sacs. They should be like this. This is normal. This is dilated, which is tubular, right? Then you got varicose, where it's constricted and wide. And then you have just straight up sacs, right? These are sacs. They almost look like alveoli, but they're not. Those are the bronchi. Those are the bronchi doing this, right? This is not alveoli. This is bronchi. They should not look like that. All right? So that will be your saccular or secular one. Okay, so here we go. Got the normal, should be small and nice. Tubular is, they look good, but they're uniformly dilated. Okay? Varicose is you're going to have areas of constriction and dilation. And then saccular is just straight up sacs. They look like sacs, but they should be tubes. Okay? All right. So here they go. Cystic or saccular is the most severe. The cystic or saccular form of bronchiectasis is the most severe. Progressive distal enlargement of the airways. As they go down, they get big, right? They get real big, look like sacs. All right? Third or fourth generation of the bronchioles become severely dilated. So it's just, see right here, look at this one. C is the saccular one. Start out okay and then turn into a big sac, right? Varicose is the first one, fussy form, right? You have some small here. Look out, this is kind of constricted, but this is wide, right? Wide, then get back small again. Or you have it looking like this and maybe, you know, normal look and then get big and then back to normal again. This is alternating, right? This is varicose. Cylindrical is tubular. It's the one that looks the best, right? Look at this. It looks normal, right? But actually it's bigger than it should be. And if it's bigger than it should be, that's considered cylindrical or tubular bronchiectasis. And, you know, it looks good. That's why it's the mildest form, right? That's why it's you barely can tell you got that problem because that's the mildest form, all right? With the cystic or the saccular being the worst kind, okay? That's the worst one you could possibly have. So bronchiectasis, whether it is diffuse or local, has 3 classifications, either varicose, cylindrical, or cystic. Cylindrical is the mildest and cystic is the worst, okay? That's what you need to know. This is how it looks like on a CT scan. Awesome. Awesome. Look at this right here. This is the tubular. I should not be able to see it like this on a CT. If I can see it, that's because it's bigger than it should be. But you see this? Look how, you see how they're tubular? They're all the same size pretty much. These are the bronchi, right? You should not be able to see that on a CT. Okay, they're wider than they should be. Okay. Let's look over here. Okay, so cylindrical is the one that is tubular, right? Tubular and cylindrical. Look at it. You see it, how wide they are? Right there. That's wide. That's wide. You know. Then you get into varicose. Look at this one. You got wide. Look, wide and fat, and then it gets, look, it gets skinny right here, right? This is skinny, but then they get super wide. Look at this one right. This is the best one right here is this one. You got regular size right here. That's the regular. Then it, look how big it gets, wide and big, right? Then back down to small. Look, those two right there are small, right? So that will be varicose. Then cystic is just like a bunch of black bubbles. Look at this down here. Look how they're just bubbles. They shouldn't, these are your bronchi. They should not be looking like this, right? They should not be looking like this at all. This is the worst kind, the cystic. Look at that, how big that is. So it comes out like this, and then it ends up as a little a bubble at the end, right? This is normal. Well, this is really wider, but you got the tube, and then boom, a big sac, right? Tubes, and then sacs. This is not how it should look. This is bronchiectasis from a CT scan, okay? Awesome. The tubular also has, you don't have to worry about it, but it's called the signet ring. You know how a king has a ring, he put his ring on a note to signify that he wrote the note or whatever. It looks like a ring, right? It looks like a ring, but don't worry about that part. You just need to know the 3 types of classifications: cylindrical, varicose, and cystic. Cylindrical is the least severe, cystic being the worst, okay? Right. Now, this is a lung right here with, this is one with bronchiectasis, okay? This is a cross section of somebody's lung who smoked. That's why it's not pink. It should be pink, but it's almost black from smoking. So if you smoke every day, been smoking for years, this is what your lungs look like. Okay, they might not show, you might not have bronchiectasis yet, but this color is how your lungs look from all of the smoking. Okay, smoking blunts, whatever you smoking, it's what it looks like. Vaping, all that, this is what it looks like. Okay, that's what it looks like. All right, so this one is really, this is the cylindrical one. This is the sacral or cylindrical, the one that's worse. Look at these pockets. See how they end up in pockets? Normal, and then they end up at the end. The distal ends are pockets. Gross. That's a slice, right? Say slice somebody's lung and show it to you. All right. Now, there's another key telltale sign of bronchiectasis, and that is 3-layer sputum. So in the hospital, you have a canister of secretions, right? When you sucking the patient out or at their mouth, when you go down in their trach and suck that stuff out, it goes into a collection container called a suction container, right? After a couple of days, that patient has collected a lot of sputum, a lot of mucus. But when you look at that container, the suction container on the wall, which is a little red container, okay, it'll have 3 layers. The sputum changes into 3 layers, right? I think I even took a picture of that and sent it to y'all before. Yeah. Oh, okay. Well, that classic sign of bronchiectasis is 3 layers of sputum. 1, 2, 3. You can say, dang, why is his sputum changing to 3 layers? Because he got bronchiectasis. Telltale sign, okay? The top layer is a real thin, frothy layer. The middle layer is micropurulent, so it's mucus and pus, all right? And the bottom layer is purulent plugs, right? Pus and mucus plugs, so it's heavy. It's almost like sand at the bottom, right? This thick, they call it ditch-rich plugs, but I don't know what that is. But the bottom layer is almost like sand. It's pus mixed with a lot of mucus plugs, so it's like hard booger-like material at the bottom. At the top is just a little thin layer of froth, and in the middle is pus and mucus. Gross, okay? That's what's in their lungs. Stop smoking, right? It manifests this way. So if you see that, that patient has bronchiectasis, okay? If you see that, he has bronchiectasis, okay? Also, VQ mismatch leading to dyspnea and respiratory failure. PFTs have reduced FEV1s percents, right? So reduced flow. This is all letting you know you got COPD or some type of obstruction because your FEVs will be low, right? Can't get the air out. This patient might even have hemoptysis. That's breathing from the mouth, right? Coughing up blood is hemoptysis. Recurrent infections, and finally, digital clubbing. Digital clubbing is when the fingertips look like drumsticks. Okay, that's a sign of COPD. Yep, that person has COPD. Whenever you have fingertips, the tips of your fingers, they look like drumsticks. Okay, I'm gonna show it to you right quick. They have COPD. All right, let me share my screen. If you see this on a patient, that's COPD. See how the ends of their fingers are swollen? They look like little drumsticks at the end. That's COPD. Digital clubbing, look at that. Clubs out. That's digital, look at that. That, guys, is digital clubbing. Look at this one. You got blunting fingertip. The fingernail tips are fat, they're round and just like drumsticks. That is COPD. This telltale sign of COPD. If your patient, and this kind of stuff when you're assessing your patient, right? You're looking for chest rise. You're looking for accessory muscles, right? Are they tripoding? Are they using their scalene muscles or the sternocleidomastoid muscles, right? Are they diaphoresis? Pursed lip breathing. Look at their fingers. Are their fingers clubbed, right? Look at their color, if there's blue or pink. All those kind of things is part of your assessment. Remember, you're assessing your patients from the moment you walk into the room until you leave. Assessment, assessment, assessment. All right? And so this is an example of digital clubbing, which is a telltale sign of COPD. All right? Let's keep going. This is another little diagnosis and treatment. A CT scan is the standard. That's what we do. It's hard to see on a chest x-ray. But this right here, if it's real bad, you can see it. Look at this. Look at that. You should not be able to see this on a chest x-ray. That's because all of these bronchioles and stuff are dilated. They're dilated. So since they're so thick and dilated, you can see them. This should just be regular blackened ribs, right? But since I can see all this, it's because they have bronchiectasis. That lets me, it looks pretty, it looks cool, but it's really bad. And look down here. Look how it's secular. See them sacs? See, it comes down and then it ends with a bag at the bottom. See this little round part right there? That's saccular. This one he might even have more than, you can have more than one type, right? You can have more than one type. But this is how we look at it. That's bronchiectasis. Now, how do we treat it? Aggressive bronchopulmonary hygiene. Aggressive, because he got pus and mucus all in his lungs. You gotta get it out of there, right? Bronchodilators, antibiotics, and lung resection for severe cases, right? So you might have to cut a piece of the lung out and resect it with the next door neighbor part of it, all right? Because it's just so ate up with bronchiectasis. All right, last one, and this is going to be the end of obstructive lecture. The last one is cystic fibrosis. Cystic fibrosis is a hereditary disorder. You don't catch it from smoking. Cystic fibrosis is hereditary. It affects mostly Caucasian children, okay? Mostly Caucasian children get cystic fibrosis. Very rare where you see it in any other race, okay? It's hereditary disorder affecting the exocrine glands. It causes the production of abnormally thick mucus, leading to the blockage of the pancreatic ducts, blockage of the intestines, and bronchi, and often result in respiratory infection. It's a terrible disease. And not only does it affect the lungs, but it affects your intestine and your pancreas. That's why these children can eat, but never gain weight or always look malnourished. Okay, they always look just, you know, you can see somebody just look sick. You're not getting no nourishment, right? Because when you eat food, the intestines have to absorb the nutrients, right? And then give it to the bloodstream. But if the intestines are full of mucus and blocked, the ducts of the intestines are blocked. So the food goes in, but it comes on out, right? It's usually not digested. Some of the food comes out, don't even look like it got digested that well, right? Because it's blocked. It cannot absorb or digest it properly, right? It also affects the reproductive glands, right? You have reproductive issues. The pancreas is all jacked up, right? And then ultimately the lungs. Epidemiology is one of the most common life-limiting autosomal recessive diseases. It's genetic and it's life-limiting. They don't live that long. They used to really didn't live long. They're getting better now, but they don't live that long. It occurs in approximately 1 in every 35,000 newborns. 3,500. So that's a lot. 1 in every 35, huh? Mm-hmm. 1 in every 3,500 newborns has cystic fibrosis. It affects approximately 30,000 people in the United States and 70,000 worldwide, I guess on average a year. Majority people of Caucasian descent. Look at this baby. This is what their life is like every single day. Breathing treatments. She got the vest on. See, she got the high flow oscillation chest wall oscillator. She got that to shake her lungs so she can cough that little stuff up. She's full of pus and mucus. Okay. This is how, you don't have to remember this part, but this is showing you how you get it. Okay. Pretty much just going by your parents. So let's look at an example. If half and half means you're a carrier, they don't have it, but they're carriers of it. Okay. So if two white adults who are carriers of the disease, right? If they have 4 children, then 1 will not have it, 2 will be carriers, and 1 will have it. Okay? This is what it's showing you. 2 carrier parents, half and half, mean they don't have it, but they carriers of it. If they have 4 children together, 1 of them won't be a carrier or have it. Okay? 2 of them will be carriers of it. And then 1 of those 4 children will have it full blown. Okay? All right, look right here. If you have a parent that's a carrier and then another one who has it full blown, then when they have children, 2 of their children will have it full blown and 2 of them will be carriers. Okay? And then a non-carrier parent and a straight up full blown parent. Okay? All 4 of your children will be carriers. Okay, all 4 will be carriers. Like I say, this is not test stuff. I'm just trying to show you how you get it. All right. And how you eradicate it will be know if you're a carrier. If you're a carrier, you don't need to have no kids. I mean, that's cruel, but look at what you're about to put your child. It's a chance you're going to put your child through a hell life. All right. It's breathing treatments and chest PT and drainage and coughing and antibiotics for the rest of their life.
So if you're a carrier, it's not anything that they can do.
I don't know. It's genetic.
It's just,
It's genetic. If you're a carrier, you're a carrier. Right. I don't know if there's some way you can block it from. I mean, they got new stuff out there these days with genetic tracing and all that kind of stuff, but I wouldn't risk it. I would adopt. You just want to have a child adopt because you have to put a child through something that's not necessary. It's just until they got a cure for it, why would you do that, right? And then this one, if you have a non-carrier parent and a carrier parent that don't have it, but they're just a carrier, then two of them won't have it at all or be carriers, and then two of them will probably be carriers. Okay, so you're fortunate. If you don't have it and you know she's a carrier, then just know that two of y'all children will be normal, but two of them will be carriers. So when they live life, if they get with somebody who has it, then one of their children are definitely going to be full blown. Okay, so that's just one of those things. Okay, cystic fibrosis is a terrible disease. All right, manifests with respiratory, digestive, and reproductive tracts, impaired secretion clearance, which leads to infection. You can't get the infection. I mean, the secretion's out, then they're going to draw and turn into infections. PFTs, of course, will have an increased FRC because they can't get the air out, right? This is still obstructive disease. They're going to have an increased TLC, an increased RV, right? All that's going to be high because they can't get the air out. Now, they're going to have a decreased expiratory volume, forced, right? Because they can't get the air out. So, I mean, it's all common sense as far as COPD. All of their numbers are going to be about the same. For all the C-babe diseases, their PFT is about the same. They can't get the air out. And if I can't get it out, that means my FRC is high, my TLC is high, my RV is always high, right? And my expiratory volumes that I'm trying to force out is going to be low, okay? My vital capacity is going to be low. I can't get it out, okay? Chronic cough, productive cough with tenacious secretion. Tenacious is thick like bubble gum secretion. Cough up some bubble gum like secretions, right? That's what tenacious means. Lung hyperinflation and bronchiectasis, like a barrel chest. 85% have endocrine. Don't worry about that. Don't worry about that. Digital clubbing is present in many patients, but this is not a universal sign. So digital clubbing may be present in your cystic fibrosis patient, but it's not a universal. Bronchiectasis, it is universal. All your bronchiectasis patients will have digital clubbing, okay? All right, that's cystic fibrosis. How do we treat it or diagnose it, right? We just talked about how we treat it, but what about diagnosing it? CF is confirmed by a sweat test. You need to highlight that. The sweat test, okay? A sweat test. What they do is if you, they taste the sweat of the baby's cheek. Right, that's one way they used to do it back in the day. They taste the cheek. If it's sweet, it's CF. Okay?
Taste it like
Taste it, yes, taste. It's a sweat test. It's a sweat test. And they can tell, like a parent can taste the baby's cheek if it's, because, osmolality of the lungs should be salty, right? Sweat and stuff like that, that salty taste. But if you lick or taste the side of your baby's cheek and you suspect it and it's sweet, then that is a sign of cystic fibrosis. Okay, the sweat test. All right, of course, you have a sweat test, PFTs with the regular PFTs. That's how we determine it. Then we look at the family history because we know it's genetic. So I'm looking for a history of CF, especially in their siblings. Okay, do you have a brother or sister who has it? Then you probably got it, right? That's probably what it is. So we're looking to see, why do they have these issues? Why do they have all this stuff they coughing up? What is the problem? Then we start trying to narrow things down to what it may be. Okay, reoccurrent sinus infections or lung infections, chronic cough, nasal polyp, digital clubbing, malnourishment, poor weight gain, good appetite, but failure to thrive. They can eat now. They hungry, but they malnourished. Like you see somebody who's malnourished, you think you need to eat a sandwich or something. What's wrong with you? So skinny and frail and just look pale and sick. But I just ate a whole pizza. I eat, but the nourishments are not getting to the bloodstream because those intestinal ducts and pancreatic ducts are clogged up with nasty, hard, thick mucus. Okay? As I'm telling you, it's a terrible disease. So why would you have children if you know you are a carrier of it? I just don't understand that.
A lot of people don't know they're a carrier, but I'm guessing.
I don't know, but it's kind of hard not to know because somebody in your family probably has it. You know what I'm saying? I mean, it's possible, but I just, I wouldn't know. You need to find out as much as you can before you have kids in this world today. All right. Failure to thrive. Prognosis. Now, it was first described in 1938. Children lived 6 months. When they confirmed you got CF, they lived about 6 months, and that was it. Now, 41. 41 years old is the average age, and then they die after that. And that was in 2012. So as, time gets better, right? In 2002, it was 31. Now in 2012, it's 41. So now it's 2020, it may be more. I haven't checked it to see, and it's getting better and better. Thank God it's getting better and better, but it's still for all them 41 years, you got a basket of medicine like this every day. You got, the basket I show y'all when I have all these different peak flows and all this stuff. That's what it looks like by their bedside, right? That's what it looks like. It's just constantly, constantly medicating. Look at this basket right here. Treatment. Look at that.
Oh my God.
You just got a basket full of stuff that you got to do every day. And it's, that's your baby, your 5-year-old, your 6-year-old. You got to go through all of this with them every single day just to be able to breathe good, right? It's got to be very stressful. Right, so we treat them. We're closely monitoring them by the CF Center. They need to be followed by a cystic fibrosis doctor, a special place that's for cystic fibrosis patients. Multiple therapies, guys. Multiple things you got to do to keep them right. Oxygen, bronchodilators, mucolytics, good hygiene, right? The PEP, flutter, acapella, chest vest, antibiotics, inhaled steroids, pancreatic and vitamin supplements, and lung transplant if you can. That's a lot for CF. Now, let's look at some of those medicines. We said Dornase alpha was what we use for our cystic fibrosis patients, right? Well, that's Pulmozyme, right? Pulmozyme. And then you got acetylcysteine, which is Mucomyst. Or we can use 7% hypertonic saline, right? Those mucolytics, because this mucus is causing the problem. The mucus is what's causing the problem. All right, antibiotics. They got some non-inhaled, like streptomycin, but then you can do inhaled gentamicin, right? Tobramycin and gentamicin can both be given inhaled or IV. Okay, they can give tobramycin IV as well. But steroids, corticosteroids, now it says they're not recommended unless there is some airway reactivity and only with adults. So try not to give the steroids to the babies if you can. But all this is the treatment for cystic fibrosis. So what you need to know, I'm going to say that all you need to know, but some highlights of cystic fibrosis is that it's genetic. And we treat it with Dornase alpha. That's the one we use for cystic fibrosis, right? Of course, all of the different PFTs you're going to see as of any other obstructive disease is diagnosed with the sweat test, right? We can use this. So if you see sweat test on a question, they're talking about cystic fibrosis, okay? And it's really a bad thing. All right. All right. Bronchiolitis, I thought that was the last one, but bronchiolitis is the last one. It's only a couple. Bronchiolitis is the last CBAB disease. Bronchiolitis, which is infection of the bronchiolitis, would be infection of the bronchos.
Bronchus.
The bronchiole, yeah. I'm just going by the word. Bronchiolitis is inflammation of the bronchioles. Okay, bronchiolitis. Acute infection of the lower respiratory tract, usually called by RSV. So RSV, which is the respiratory syncytial virus, causes bronchiolitis. How do we treat RSV? What medicine do we give to treat RSV?
Is it exocert?
Ribavirin.
Ribavirin. Remember, we use ribavirin as an antiviral breathing treatment for RSV. Respiratory syncytial virus is RSV. We treat that with ribavirin, right? But what it causes, that virus causes bronchiolitis in the infant, okay? The virus is the RSV, okay? That's a virus, but it causes bronchiolitis in your infants, all right? It affects 1 in 10 infants, good prognosis. Most of the don't have to worry about that. What you need to know about bronchiolitis is it's caused by RSV, and we treat it with ribavirin, okay? Don't have to worry about this age stuff. Now, manifestations of bronchiolitis: edema of the small airways. Just look, small airways swell up, okay? Increased mucus, intermittent cough, polyphonic wheezes. That means the sounds of the wheezes are different. You might have high pitch, low pitch, medium pitch, just depends, right? Retractions. Retractions is the baby's breathing and he's sucking in his neck a little bit more because he's letting you know he's working, right? Retractions are a symbol of accessory muscle use in babies. Retractions, when the under their rib cage kind of sucks in a little bit when they're breathing, or right here above their suprasternal notch sucks in every time they breathe. Those are retractions, okay? You might even see this. Nasal flaring, right? Every time they breathe, their little nasals open up. That's all accessory, the body trying to get more air in, okay? Chest x-ray usually shows hyperinflation from air trapping, areas of consolidation, right? That's not that important. But bronchiolitis is inflammation of the bronchioles caused by RSV, and we treat it with ribavirin, okay? That's the basics of it. And it's in my infants, all right? We treat it with oxygen, of course, high flow nasal cannula if we had to, aerosol tent, right? We can use a little aerosol tent, a little oxy hood or something like that if we need to. Don't forget that's what we use on our kids. Bronchodilators, if there's bronchoconstriction element. If there's no bronchoconstriction, then don't use a bronchodilator. Bronchial hygiene. Now, CPT is discouraged, right? You don't want to be beating on a baby, okay? But you do nasal suctioning with a little bulb. That little bulb suction, suck that stuff up out of them. That'll help pull it out. Might use a little 3% saline, right? Remember how you put that little saline in the baby's nose and loosen it up if it's too thick. And you might even give them a little racemic epi. Sometimes they give a little racemic epi in those because of the inflammation and swelling. Remember, I said lower airway edema, so that's swelling. And we know that racemic epi can reduce swelling, right? Because of the alpha stimulation, vasoconstriction, okay? And how do we give ribavirin? How do we give SPAG? The SPAG generator, small particle airway generator. That's how we give ribavirin. We can't give ribavirin in a regular nebulizer. It has to be given via a SPAG, right? The SPAG, that's what we talked about in the last unit. Ribavirin is given through a SPAG generator. That's it right here. It looks like this, okay? The SPAG, small particle airway generator. That's how we deliver ribavirin, because you don't want to be breathing in ribavirin, okay? You don't want to breathe in ribavirin. You can look on, I implore you guys, go to YouTube and look up SPAG, look up small particle airway generator, aerosol generator. And they'll show you how they hook it up. They'll show you how you deliver the medicine. There's, videos on the SPAG if you want to, just so you know what it looks like. And then antibiotics to control secondary infections, because when I have RSV causing my bronchiolitis, you don't give antibiotics to a virus, right? But we may give antibiotics to control any secondary infections that come about, right? So now that, he has RSV, but now he also has some type of bacterial infection because of the bronchiolitis and can't get the stuff out, right? You can't get the secretions out. They start setting up infections. So all these things will happen. So they'll probably give them some amoxicillin, right? To help any kind of secondary infections. That is all of the C-babe diseases, right? You got COPD, baby, right? The C-babe diseases. Where? Feel free to go back and look at this PowerPoint so you can be up on it. Tomorrow we're going to talk about restrictive diseases, okay? Tomorrow we're going to talk about restrictive diseases. And there's a PowerPoint for that one. So make sure you print out your restrictive and have that ready for tomorrow. So when we go over it, you're ready. Okay. So just to wrap it up, obstructive diseases are cystic fibrosis, chronic bronchitis, asthma, bronchiectasis, emphysema, and bronchiolitis. We said cystic fibrosis quickly is genetic, right? Comes from this, you can test it with the sweat test to see if they got it. You learned all about that. Chronic bronchitis, main telltale sign is thick gray sputum, right? They have a cough for 3 months, right? A year and more than one consecutive year, right? That's chronic bronchitis. Asthma, we learned all about asthma and how it's either allergic or non-allergic, right? How we treat it using the green light, red light, and yellow light, red light, I mean, whatever, you know, the stoplight thing. How we treat that at home. Bronchiectasis was the nasty one. That's the one that has 3 different classifications. You got saccular, which is the worst kind. Then you had tubular, which is the least mild, right? And then you had varicose, which is different sizes, constriction, dilation of the bronchi, right? All right. Then emphysema was either panlobar or central lobar, right? Panlobar usually is the genetic one coming from the alpha-1 antitrypsin deficiency, right? And the central lobar is the most common one, right, which comes from smoking, okay? And then bronchiolitis happens when the baby has RSV. RSV causes bronchiolitis, and you just learn how to treat and how to know bronchiolitis. We have to treat it with ribavirin, right? Suction the baby out, lose a little medicines, and may even give them a little antibiotics for secondary infections. And the medicine that we give, which is ribavirin, is given through a spag. All of these diseases will have high FRCs, high residual volumes, right? Because they can't get the air out. All of these are obstructive diseases. So the PFTs will all show a higher volume left because they can't get it out. Now, when it comes to the peak flow, right, this peak flow meter is able to force expiratory flow, which is the FEVs, forced expiratory volume, is going to be low because they can't get the air out. So that measurement will be low, right? So those are the basics. Go back and look at that. Look in your book. Matter of fact, since we did this one first, go into your Egan's book and look at in the index for obstructive diseases, and that will tell you what chapter to go to read about obstructions. Okay, go to your index and go look up obstructive diseases, obstruction. All right, go find obstruction. On my O's. Oh, I thought O's.
Now I got this book and not the other book.
Either one.
No, I'm talking about my lab book.
Oh,
I need
okay.
to sign it anyway. I don't grab it.
Okay. Obstruction. Okay. Obstructive pulmonary disease, 397. So page 397 is chapter 397. Yeah. Pulmonary function testing. That's one of them. Pulmonary function testing. Yeah. Chapter 20. Chapter 20 will talk about pulmonary function. We'll talk about obstructive diseases, right? It's going to give you your obstructive diseases and how we check the body box. Yep, all of that. I'm coming from chapter 20 of your Egan's book. We'll talk about as a matter of fact, it's going to talk about restrictive and obstructive diseases in that one chapter. All right, but anything like that, whenever you're not sure or it's not written down, go to your index, and your index will tell you exactly where to go find it in the Egan's book. Don't forget, not just this PowerPoint, but look at the book, read. That's how you find all the information that you need, okay? So chapter 20, is one of the chapters. I think that's really all you need to worry about would be chapter 20 for obstructive diseases. So look on that tonight. Yep, the plasmography box. That's the body box. Plasmography. That will be the body box. But like I said, whenever you're looking for some guys, you know, I ain't see it on the syllabus. What chapter? Go to your index. Go to your index. It's going to tell you exactly where you need to go. So obstructive lung disease. All right. So I'm on the index. I'm looking at obstructive lung disease, page 510 through 537. And then obstructive pulmonary disease was also on 397, right? So I'm gonna go to 510. So we know chapter 20 is part of it. Let me go to what chapter is page 510. 510 is obstructive lung disease. Whole chapter for it. So that's gonna be a better chapter. Not only that one, but chapter 25. So chapter 20 and chapter 25 will give you good information on obstructive lung disease and restrictive diseases, okay? Some of these pictures come straight from this book. We just showed it. Talking about cigarettes, smoking cigarettes, shows you bronchiectasis. Great information. That PowerPoint we just did, a lot of it comes right from the book. And it's even got your medicines in here, okay? So chapter 25, guys. Chapter 25, you can peruse through chapter 20, right, for tonight. And then tomorrow we'll talk about restrictive diseases, and we'll see if that's in the same chapter, or do they have their own chapter for restrictive diseases. Very interesting. Restrictive is really cool, okay? It's a cool, you know, it's sad for the patient. I'm not saying it's cool for the patient, but it's really interesting. Restrictive. Okay. Restrictive pulmonary disease. Yep. 397. Yeah. So 20 and 25 will be for this whole thing as far as obstructive and restrictive diseases will be in page chapters 20 and 25. Okay. So look at those tonight. Be prepared tomorrow to discuss restriction. The PowerPoint is already loaded. If you want to go and look at the PowerPoint for restrictive tonight, whatever you want to do. I'm about to convert this video and have it posted on the website, but the module for you. And then tomorrow we're going to go into restrictive. Okay. Good job today on the test. If you did not pass the test, be looking for the practice and review. Now, homework tonight, I will put in, it's going to be a comprehensive stuff. We'll start now to start looking at comprehensive review, going back to 210A, B, C, those questions that make you go back and study. That's what's going to be for homework tonight, okay? So I'll put it in, be looking around 3 o'clock, 4 o'clock. By the time I can get home and get everything set up, your homework will be in there, and also an announcement I'll make to find this stuff in chapter 20 and 25 of the Egan's book, okay? All right, have a good day. Good job today.